Good morning. We've been delaying starting the hearing just to see if there was anybody running late. I'm going to let the members come up to take their seats, and then we'll start this hearing in just about 1 minute. Actually, with this, I'll open our day. Right now, we will be hearing House Bill 1660, and then later in the afternoon, we'll move across to the LOB for our other bills. As we get started, I'd ask everybody to join us in the pledge. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Thank you very much. I would like to open the hearing on House Bill 1660 and recognize prime sponsor, Representative Jim Cofalt.
Thank you, Madam Chair. I'm going to keep this very brief. House Bill 1660, quite simply, would explicitly exclude coverage of transgender surgery for minors in the state of New Hampshire. Despite statements that we've heard that it's not happening in New Hampshire, I think in previous hearings before this committee and executive sessions, it is quite apparent that healthcare providers throughout the state of New Hampshire are, at the very least, advertising such services. If we were to pass this, we would join 11 other states that explicitly prohibit coverage. 3 of those only explicitly exclude coverage for transgender surgery for minors. The other 8 exclude transgender surgery for all ages. Another 12 states and 3 territories have no explicit policy. That concludes my bill introduction. I'll take any questions.
Okay, thank you. Representative Weber?
Thank you, Madam Chair, and thank you for taking my question. My question is, when we say any form of gender reassignment surgery, are we talking top surgery as well as bottom surgery?
Yes.
Thank you.
Follow-up?
Yeah.
Follow-up.
The other question I had was, do we know if Medicaid funds are used for either breast augmentation or breast reduction surgeries for other purposes?
I don't know the answer to that.
Okay, thank you.
Thank you. Representative Murphy?
Great, thank you, Madam Chairman, and thank you for taking my question. I've heard in other settings here in the House and in committee that these surgeries, and I think specifically they're talking about bottom surgery, is done in the state of New Hampshire. And you just mentioned that at least advertised as such. So do we have any, I'm trying to get a handle on exactly what is done or not done. Have we in the state of New Hampshire done any gender reassignment surgery, and specifically any bottom surgery, not aesthetics and upper surgery, but just any gender reassignment surgery under the age of 18 in any possible? And if so, how can we get that information? Because I hear conflicting reports, and I'm just trying to be clear about that.
Thank you for the question. I don't have access to that information, so I don't know. What I do know is that in 2017, the DHHS implemented a policy through rule that would authorize the state's Medicaid program to cover these kinds of surgeries for Medicaid recipients. This bill would simply exclude minors from being covered under that rule.
Follow up?
Thank you. And the other question I had was, if we're not doing, are these other surgeries done, say top surgery, any, breast augmentations or reductions for other medical reasons other than transitioning surgery? If they are done in the state of New Hampshire, would they still be covered or not under this bill?
This bill expressly uses the language gender reassignment, sex reassignment.
So just a quick follow-up. So that would mean to me then that this is done specifically, I wouldn't say targeting, but specifically for gender reassignment, including upper surgery. And would you agree or disagree that that would represent discrimination against those who may otherwise have that surgery for reasons other than transitioning?
I would disagree. I believe that it is within the purview of the state and the state legislature to determine whether or not this would be covered under our Medicaid program. What's at issue here is not whether or not these surgeries are legal. That was addressed in House Bill 619, which is going on to the Senate at this point. If House Bill 619 goes through the Senate, makes it through the Senate, and gets passed by, gets signed by the governor, this bill would be moot. So this does not address the legality of that. It simply says that we as taxpayers should not be bound to pay for these surgeries for minors.
Thank you. Representative Cushman?
Thank you, Madam Chair, and thank you, Representative Kofalt. Are you aware of letters that went out to minors around 2017 alerting them to a change from their managed care organization under Medicaid that gender reassignment surgery would now be covered?
You're talking about a letter that went from the state to, I'm sorry, can you clarify?
No, actually it was a letter that was addressed to a minor child, and she was a recipient of the insurance under the managed care organization, and they were just alerting the child to changes in their coverage. And one of the changes was that now, because of some rule under the ACA, that they would be offering this. So it was kind of advertised to children. Would you believe that?
I'm not aware of that letter. I would love to see a copy of it if you could provide me with that.
Representative Seth King?
Thank you, Madam Chair. Thank you, Representative, for taking questions. My understanding is this bill was filed before HB 619 was passed.
That is correct.
In the House. Would you see any merit in passing this bill even if HB 619 becomes signed into law? Thank you.
Yes, I would see merit in passing it for several reasons. First of all, I think that we ought to move forward with this bill. I said it was moot if House Bill 619 passes. I'm actually going to modify that a little bit and say that it is still worth explicitly excluding transgender surgery for minors from our Medicaid coverage in the event that the policy established under House Bill 619 were to change, if it were to be repealed, that this would still be in place.
Representative, actually, I'm going to go with Representative McLean since we've already had a couple questions from Representative Murphy.
Thank you, Madam Chair, and thank you for taking my question. So there was some questions with respect to the dual nature of some surgeries, for example, breast augmentation or breast reduction with respect to intent. One of them might be just because there's a medical need for breast reduction. In another case, it might be due to gender reassignment. Administratively, right now, if you were to have something, for example, a breast reduction, is there a way to differentiate that either in the CPT codes or anything like that between, this is breast reduction for gender reassignment purposes and this is breast reduction for other purposes, or they all fall kind of under the same umbrella at this point?
I'm not an expert on medical coding, but my assumption is that yes, that those would be covered under separate codes.
Thank you.
Representative Murphy?
Thank you once again for taking my question. So I just want to be clear, this is only for addressing gender reassignment surgery, is that correct?
That is correct.
And so my follow-up question, if allowed, would be that if the gender reassignment surgery is a medically appropriate procedure, considered so in the medical community, when discussed between the patient and the family, would the next logical extension of this bill or the next bill coming down the road be one where they would exclude, the use or the treatments for hormonal treatment, psychological treatment, social services treatment for these individuals?
This bill does not cover any of those, does not exclude any of those things.
I agree.
Sorry, Representative, I think you're asking him to read other legislators' minds, and I don't think any of us are good at that. If you want to
Just a
pose
quick
it
follow-up.
differently.
Would you be concerned that this might lead to further limitations on what is considered a medically appropriate process of gender reassignment?
My concerns focus on this bill, and that's the scope of the conversation, I think.
Thank you.
And I'll actually ask a question as well. Representative Kofalt, would you be willing to consider the idea of including all breast procedures, both in except for a medically necessary reduction because of the weight causing back problems for other children, to exclude those surgeries for both transgender and for other children as well, because breast augmentation and elective reduction carries risks in the youth as well.
I think an amendment that clarifies that would be absolutely appropriate.
Thank you. Are there any other questions from the committee? Seeing none, thank you very much.
Thank you.
Next, I'll call Dr. Jennifer Smith from Pembroke.
Good morning, Madam Chair, members of the committee. I appreciate your taking testimony. As a physician, I'm retired, but as a physician, I spent a career taking care of people who could not afford regular insurance for the most part. Some could, but most of my practice ended up with being people who are currently now, more of them, covered by Medicaid, and I might not have gotten quite so poor had I had that opportunity during my career. But my objection to this particular bill, and leaving quite aside how you feel about minors accessing gender-related care for transition, is the same as I had against a bill several years ago that tried to say that Medicaid could not cover circumcision. There were some activists who felt that circumcision of infant males was a terrible thing that was being inflicted and wanted to have it banned, but they couldn't figure out how they would get it banned, so they brought a ban against Medicaid. Fortunately, that bill bit the dust pretty quickly because people realized how discriminatory that is. And my concern here is part of that slippery slope is next thing we're not going to allow hormone treatment, we're not going to allow the other things that are life-saving. And frankly, I don't agree with the premise that 18 is a magic age for deciding that after a very long time going through gender transition, you should be prevented from going to that step. But, that's a different bill. And so we'll deal with that separately. But the idea that something that is established as good care, helping people psychologically avoid the kinds of trauma that ends up with some health plans quite some time ago deciding that it was actually cheaper for the health plan to be covering these than to have to deal with multiple suicide attempts and things of that nature. So I really think this bill has no place. Medicaid should cover everything, frankly, that any other health plan is required to cover. I don't know the legal ins and outs of that, but I suspect that the state would find itself in federal court if they passed this bill and the governor signed it. It just doesn't make sense to me that this bill is even being considered. Thank you. I'll take any questions you might have.
Thank you. Are there questions? Representative Shapiro?
Thank you, Madam Chair. I wonder if you could comment on the effect on the emotional life of transgender people as affected by bills like this, which limit coverage, but also a large number of other bills that limit coverage or limit procedures or limit limit procedures and limit services for transgender people. I wonder if you could comment on how that affects the emotional life of people.
I think it's pretty severe. I am active with PFLAG in this area, and we have a host of families who have come through PFLAG. Some of them have moved on and don't need the support system, but they are really negatively impacted by these bills. Their children are scared. They are scared for their children. People who've already moved from one place because of local opposition at the school board level and so forth. Do we have to now move out of state? You know, those kinds of things are very real. Do I know how many of those are Medicaid covered? No, I don't, and I don't really think it should matter, and that's my objection to this particular bill, is it discriminates against Medicaid-covered individuals for something that is available potentially to others. Although we've heard that it isn't available in this state, I am quite clear it is available elsewhere, and I frankly think it should be. And I could go into a lot of elaborate reasons for that, but I won't, because that's not this bill.
Thank you, doctor. I have a question for you. My question would be that as a doctor, you're probably aware that most insurance coverage, and especially Medicaid, is based on the clinical data that supports the benefit and speaks to the balance of risk and benefit of a procedure. I was wondering if you could provide us any information, any clinical information on the safety, efficacy, and risks of these procedures in minors, understanding that children aren't small adults and the medical history of children who've transitioned early is different than adults.
That's a complicated question because there's a whole range of people involved. But generally speaking, these are not things that are done on an experimental basis. You know, the background is years of psychological care for things, and usually if transition is occurring fairly early in childhood, puberty blockers, and then moving on to cross-sex hormones. So it's, you know, since you've pushed me there, I'll say the reason I think that 18 is not a magic age is I really feel badly for the young trans person who has reached the point of going to college and is still feeling like, you know, I'm going to go to college and I'm not able to be the same as my peers. I just feel that's 18 is not a magic age, and in fact, we also know that the brain is still developing in many ways right up to about age 25 and maybe beyond. Judgment, but you still can't just say because judgment is not fully developed that people shouldn't be able to make some kinds of choices in their life with a lot of appropriate guidance. You know, the age of being responsible for your own actions in Judaism is 13. Bar mitzvah, bat mitzvah, that's, you know, to me, appropriate. That doesn't mean that the person goes off and does whatever the heck they please. With guidance, I think people can make appropriate decisions after they reach that kind of an age. And that we're certainly not talking about gender surgery at 13.
And then as a follow-up, I absolutely commiserate with you about the challenges about reimbursement and the lack of data, and the idea that you want to make sure that this is paid for as what you believe is life-saving care. I worked with life-saving cardiac devices that were not covered until they were... Sorry. I worked with life-saving cardiac devices. Sorry.
Thank you.
I worked with life-saving cardiac devices that were not covered by Medicaid or insurers without data. If you could provide any data about this in this population to the committee, I'd really appreciate it. I know that you've spoken about it, but I'd love it if you could email anything that you
Okay.
have for us.
I think it's a different bill that you're then addressing because that bill, I guess, has already gone over to the Senate, and I'm reluctant without sitting down and doing a lot of up-to-date research. I do that kind of thing when I need to. I have not done that yet on that particular issue. I know that in the past there has not been a question about that, and the major medical organizations from the American Academy of Pediatrics and all of the psychological organizations and psychiatry organizations don't see this as being something that's problematic. So,
Thank you. Okay, Representative Bill King and then Representative Mazur.
Thank you, Madam Chair, and thank you for taking my question. Since you're a doctor and you've also talked about the age of 18 being questionable on whether that's the set guideline that we should use, I was wondering if you could elaborate a little bit on brain development and how many brains aren't, especially male brains, aren't fully developed until 25.
I don't know that there's use in elaborating that. It's true. There's no question about it. I look back on myself before I reached my mid-20s, and I wonder how I survived, you know? I think that's common knowledge now. I don't know that I could elaborate on it. I'm a family physician. You know, my interests are wide. I also have a public health degree, and I've read a lot of stuff. But am I an expert on brain development as going through adolescence? No.
Thank you. Representative Mazur and then Representative Weber.
Yes, thank you, Madam Chair. Thank you for taking my question. So to clarify, because I'm still unsure, are you saying that gender transition surgery should be covered by Medicaid at any age?
If it were covered by other insurance, yes.
At any age?
If that were a decision that had come down for other insurance, yes, but that decision has not come down at any age, and I don't think it will. You know, I think the transition procedure is long. The notion that people are doing surgery on young children is just wrong. It doesn't happen.
Follow up?
Well, yeah, thank you for taking my follow-up. So I know several people who are in the process of actually detransitioning. Should that be covered for them as well?
I would think
At
so.
any age? They're
I would
teenagers.
think anyone who is in need of medical services and has appropriate medical care and psychological care should be allowed to access that care. Absolutely.
Thank you.
Representative Weber and then Representative Cushman.
Thank you, Madam Chair, and thank you for taking my question. The microphones are a little peculiar, so I'm trying to find the right spot. Would you agree with me that, as a follow-up to your point about 18 not being a magic age, that there may be a child at 17 who had been for many years undergoing the spectrum of care that comes with a transition, who might well be able to consent with the consent of their parents to a particular procedure where we all know 25-year-olds who shouldn't have care of a goldfish, but that there is a spectrum and each person falls at a different spot on that spectrum based on their own makeup, based on the quality of family care they have had, based on the quality of mental health and physical health care that they have had. And they arrive at the right point in different ways by very different means.
I couldn't say it better than you just said it. Thank you.
Representative Cushman?
Thank you, Madam Chair. Thank you for taking my question. So as a doctor, do you agree that an adult who has gone through puberty and has completed their growth in their genital area and all of the tissue development that comes with that after puberty, that a surgery to take that tissue and change it into something else is a lot different on a minor or a young person who has had puberty blockers and cross-sex hormones that have contributed to atrophy or an absence of development of that tissue? Do you see how that is novel to be, and it's breaking ground to do such surgeries, as they're very different from adults?
You know, it's an interesting question, and I have gotten a little tiny bit of information that I've heard from people, and I know nothing more about that, and I don't think the legislature should get into the business of trying to legislate the minutia of what's appropriate medical care. That's what we have all of our specialty societies for. There are malpractice laws. You know, I think you're asking something that I cannot reasonably answer, nor do I think it is germane to whether or not you should exclude Medicaid coverage of something that other insurance has decided is okay.
A follow-up?
Thank you. Respectfully, if there's no data and we have such a difference in the procedures and how they're done on a patient
I didn't
who's
say
developed
that.
and not,
You put that word in my mouth, that there's no data. I did not say that. I said I am not that familiar with it.
okay. Well, experimental care, as I see it.
I didn't say that either.
Actually, I think we'll probably stop that line of questioning because I recognize that you don't have that area of knowledge. And we can
Exactly.
pursue that. Representative McLean?
Thank you, Madam Chair, and thank you for taking my question. I just want to follow up a little bit on some of the concerns you expressed with respect to the legal jeopardy that the state may put themselves in if something like this was to go forward. Are you aware of any other states that have similar legislation and have been exposed to some of the legal jeopardy that you're concerned about?
No, I'm not certain about that. I think it probably is happening. I know there are suits around transgender issues for laws that have outlawed transition care, specifically Medicaid. I have not heard whether that's true or not. I just can't imagine that there wouldn't be litigation.
Seeing no further questions, thank you
Thank
very
you.
much, Doctor, for your testimony. And with that, I have my last pink card in my hand. If there's anybody else who would wanted to speak, please get that to me before we're done here. And I'd like to represent Louise Spencer from the Kent Street Coalition.
Hi, thank you, Madam Chair, and thank you to the committee for taking my testimony today. My name is Louise Spencer. I'm from Concord, New Hampshire, and I am the co-founder of the Kent Street Coalition, which is an all-volunteer grassroots advocacy organization. And I am here speaking on my own behalf, but also on behalf of the coalition. We believe strongly that people deserve access to the health care that they need. And we also believe strongly that that decision is best left between a patient and their physician. And in this instance, between a minor child, their parents, and a physician. And it's in their best interest. It's best to have them determine what's in their best interest. So we also believe that people who would otherwise be able to access care should not be treated differently just because they happen to be on Medicaid. There are all kinds of reasons that people end up on Medicaid, and to treat people differently and to create barriers that otherwise do not exist is unfair. This bill is just one of many that have been focused on transgender youth in particular. We've seen another number of bills focused on transgender people in general, but the trend seems to be on transgender youth. I've talked to many parents and some youth about the pain they are feeling of having to repeatedly come before this body to justify their existence and their medical needs. And this bill forces people to do that very thing. Again, I can't stress just how important it is that doctors and patients and parents are best suited to know exactly what would bring somebody to the point where they think that this is the next step that they need to take for their overall health, for their mental health, for their psychosocial health. I'm not impressed by how many other states may or may not be doing this. We've seen instances over and over again when states have had very misguided policies. We saw that when states banned interracial marriage in the early half of the 20th century. I think over 30 states out of 48 actively enforced those laws. That did not make them right. So the idea that other states are doing this does not in any way make it right. Furthermore, I am used to New Hampshire and have always been proud of New Hampshire for being a leader on issues and not a follower. And increasingly, it looks to me like we have been a follower on these issues. In 2018, we were a leader. We adopted an anti-discrimination bill that recognized the inherent human dignity of all Granite Staters. We are going backward here. And we're going backward because we're taking the lead from some national organizations and from other states. I think that New Hampshire should be a leader and not a follower, and that we should lead with courage and compassion. We should be focused on what this state needs and who our people are. And this bill goes against that. So I urge you, please, ITL this bill, please, and restore New Hampshire as a leader. Thank you.
Thank you. Questions from the committee? Representative Mazur?
Thank you, Madam Chair. Thank you for taking my question.
Yes.
So I am pretty disappointed to not see any healthcare providers here today, because I would ask them this question. Because we were told previously by them that gender transition surgery on minors is not happening in our state. Is that what you think is happening as well? Is it not happening, or do you see it happening?
I'm not a healthcare provider, and I really I wouldn't presume to speak on that issue. Having attended a good number of hearings where doctors have spoken, I'm aware that it's the rare instance, excuse me, where particularly any sort of bottom surgery would be the step taken. But I can't address your question. I'm sure there are healthcare providers that would be willing to address that outside of this hearing with you, though.
Thank you. Unfortunately, they haven't, but thank you.
I have a question for
Yes.
you. Do you know if there are other procedures that are covered by insurance and by Medicaid simply by the fact that a medical society has included them in their protocols and clinical guidelines? If you think about cancer or cardiac.
I'm not sure I understand the question. Can you reframe it?
My question is, just because the doctors and the medical societies think something is good, like some cancer treatment or some heart disease treatment, Do you believe that all of those either are or should automatically be covered by Medicaid?
It's usually not based just on what the medical society says. My husband is a physician, and I did a lot of billing. I worked for his practice. It's rarely based solely on the recommendation of the medical society. It's a very complex set of factors that are determined about when a procedure is covered or not. It has to do with diagnosis codes. It does have to do with whether something is considered experimental or not. It has to do with repetition of procedures. I mean, there are many factors that can come into play. There are also appeal procedures, so that things that might not be routinely covered are in fact covered when it is necessary for the medical health and well-being of a person. So there are no kind of formulas that can be applied across the board that would say yes or no. We have certain procedures, you know, if they've been found to be, you know, I'm trying to think. I was going to say applying leeches probably wouldn't be allowed, but now that's in fact used for anticoagulation. So I won't opine on that. But what I will say is that it is a very complex determination, often with many levels, that patients can appeal to in order to get the care that they need, including experimental procedures, in fact.
Thank you. Oh, Representative Mazur.
Yep, thank you for taking another question. So you mentioned that you worked in billing.
Mm-hmm.
And so did you see or the codes that were used for bottom surgeries, top surgeries, et cetera?
No, my husband did not practice in that field of medicine.
Were you aware they were in existence?
I wasn't. I mean, it just wasn't my area.
Okay.
I had no reason to do that, and also the practice has been closed now for about 8 years. So.
Okay. Thank you.
Thank you. Thank you very much for speaking with us today. And I want to thank everybody who is here today. I know we may have asked a few questions that were outside of your normal lane, but we wanted to make sure that we could have the best understanding we could, given that the turnout was not what I think any of us expected for today. So with that, I'd like to thank for everybody who is here and everybody who is watching on the live stream. And with that, I will close the hearing on House Bill 1660. Thank you. The next thing that the Health and Human Services Committee will be doing is at 1 o'clock over on the LOB as noticed in the calendar. So thank you.
wants a moment to catch his breath.
Oh, okay, not quite, okay.
I am ready. Thank you for your patience.
Okay, again, welcome everyone to the House Committee on Health and Human Services and Elderly Affairs. We have a number of public hearings scheduled for this afternoon, the first one being House Bill 1693. The prime sponsor, Representative Kevin Verville, is unable to be here this afternoon, but in his place is Representative Keith Ammon. Welcome, Representative Ammon.
Thank you. Good afternoon, Health and Human Services Committee. I was asked by the good and honorable good friend of mine, Representative Kevin Verville, to introduce this interesting bill before you to this committee. And he sent me a prepared statement that I have in front of me. I'm just going to read the statement, and I'll begin. I'll be quick. I'll read word for word. Good afternoon. I am Representative Keith Ammon, representing Hillsborough 42 and filling in for Representative Verville as he cannot be here today. I'm here to present House Bill 1693, an act relative to the use of psychedelics for therapeutic purposes. This bill is modeled off of our medical cannabis laws. It allows for the medical use of lysergic acid diethylamide, LSD, mescaline, the active in North American peyote cactus, and psilocybin, the active in North American magic mushrooms. Our medical cannabis program has been running successfully without issue for several years now. It is a proven model of success. This bill looks to expand upon that success by including more substances. These substances have been shown time and again since the 1950s to be remarkably effective for the treatment of alcoholism, drug addiction, particularly narcotic addiction, depression, including forms of treatment resistant to depression, PTSD, and fear of death among terminally ill persons, to name the most common and best studied. In fact, it has been shown that in a majority of patients, just one, quote, high dose, end quote, treatment is all that is required for successful treatment. These are not substances intended for long-term therapeutic use, although no harm has ever been observed from repeated treatment. These substances are non-addictive, non-habit forming, and have an interesting self-mechanism to prevent abuse. The more often that one consumes these traditional psychedelics, the lesser the effect on the user. This also holds true for increasing the dosage. If one uses psychedelics too often, then the effects are lost, even if larger dosages are taken. The only way for a person to regain the effects of these substances is to not use them for a period of time. Few, if any, other drugs have this effect on people. The only counterindicator for application of these compounds is for persons predisposed to schizophrenia, as it can trigger its outward onset. These substances were placed on the FDA Schedule 1 in the late 1960s as a knee-jerk reaction to social upheaval occurring at that time. Make no mistake about it, we are against the expansion of availability of dangerous and highly addictive substances like amphetamines, barbiturates, narcotics, and/or opioids. Psychedelics have nothing in common with these types of substances, and moral equivalence should not be drawn between them. We are aware that there are some that have concerns about patients using these substances without immediate medical supervision. We contend that it is a decision best made by practitioners and their patients. There is nothing in this bill that would prohibit a practitioner to mandate that the patient use these substances under direct medical supervision or under a more clinical setting than home. In fact, we believe that this would be the most common form of prescription, at least during the first or early treatments. Further, it is not unfathomable to imagine that all practitioners may insist on use only under clinical settings. Again, these are decisions best left to medical professionals and their patients. It is important to note that among these compounds, LSD is the only compound that is a man-made synthetic compound, still tightly controlled by federal law, and therefore would not be available for use except under special permit by the FDA. There are currently several groups in the USA with limited permits for LSD, mescaline, and psilocybin. Peyote only grows naturally in the desert southwest of the United States and therefore would have limited to no application in the short term. Magic mushrooms grow naturally in all 50 states and are easily grown indoors, making psilocybin the most likely candidate for treatment in the short term in New Hampshire, similar to cannabis today. This bill is a common sense harm reduction expansion of our current expanded medical treatment options in New Hampshire. Given the proven track record of our medical cannabis bill, this is a logical continuation of that legacy. In an effort to provide help and treatment to those most in need in a safe and secure manner. We respectfully ask that the committee recommend this ought to pass. Thank you.
Thank you. Are you taking questions or?
I could take the question and let you know whether or not I have an answer.
Okay. Representative Leon.
Thank you, Mr. Chairman, and thank you, Representative Ammon, for filling in on short notice. My question is if you're aware that the Veterans Administration is pursuing psilocybin for PTSD, and that if this would be something that if we were to pass it or study it to better tailor it to its needs, that this legislation would be needed in order to open up the potential for psilocybin for PTSD in our veteran population.
Thank you for the question. I'm not intimately familiar with the matter, but I have met veterans who had PTSD and used psychedelics to treat their PTSD. There's a group called MAPS, M-A-P-S. I can't remember what it stands for, but it was the representative of that organization whom I met. I think it was in Reston, Virginia, at one point. Was a veteran, had PTSD, experienced a very traumatic event in battle, and was an advocate for doing what this legislation would do. So,
thank you.
Representative McLean.
Thank you, Mr. Chair, and thank you for taking my question. So one of the things that you talked about, which is different from the cannabis, is the cannabis is more of a long-term kind of thing. And, you mentioned the fact that the therapy that would involve this kind of treatment would be high dose, and in fact, over extended period, the effects kind of wean away. So what the bill does is it says, it kind of looks like it's setting up a registry where you have a registry card. Since, you wouldn't be looking at having like a long-term thing like cannabis, would you be happy with just having the ability to prescribe the drug in these conditions, on a limited basis, as opposed to having a registry card? Or do you think that you need to have the registry card?
thank you for the question. I just want to make it clear, I don't think I'm a sponsor on this bill. I'm pretty sure I'm not. And the words that I read were written for me by the prime sponsor. So those were not my exact words, although I share some of the sentiments. To answer your question, I'm not an expert in this field, but the mind is a mysterious organ, right? And sometimes it gets, because of traumatic events, seeing your buddies killed in war or some other childhood trauma, it gets locked in a certain state, right? It's a neural network, and neural networks can get locked in something called a local minima. That's kind of like a computer science term, but it gets locked in a state that it can't break out of on its own. And what these drugs do, in my understanding, my layman's understanding, is they sort of allow your brain to establish new types of connections to sort of like get out of that stuck state. And based on what was written for me, it sounds like it only needs potentially only needs a few treatments, as you mentioned. But I think the important thing is it has to be guided by a professional, right? You need someone there with you in the room so that if you experience a frightening event, reliving some traumatic event, that there's someone there who's experienced on how to handle that. So that would be the way I would understand it.
Follow up?
Thank you. And so I recognize you're not the prime sponsor, and so maybe you're not, but it sounds like then that you don't necessarily need the registry card as long as I have the ability to prescribe it, and if I want to, prescribe it in some kind of controlled manner.
That's how I understand it. I understand it the same way that you do. Yeah.
Representative Weber.
Thank you, Mr. Chairman, and thank you. This is more of a would you believe question. Would you believe that the problem with having providers prescribe is that licensed providers can't prescribe these things because it is illegal for them to do so, and they would like to keep their license, which is why the cannabis program was set up, that the licensed provider certifies the existence of a condition, and it is the provider of the cannabis, or in this case, the substance, that then deals with the issue of type and dosage and all the rest of it, because the providers can't do that. Would you be interested to learn that?
I would be interested to learn that.
Thank you.
And it jogs thoughts in my mind too, that we see when we go to Manchester or even in Concord, we have a homeless problem, and some of those homeless people have mental issues, and some of those mental issues are from trauma. Maybe they were veterans. If there is a way to treat their condition in a clinical setting and provide relief in a short term, maybe some of those people could become more functional members of society. And there is some evidence out there that an approach like this may help some people. So,
Representative Merchant.
Thank you, Mr. Chairman. Also, thank you, Representative, for taking the question. In regards to trying to establish another oversight board, what are your thoughts on having the existing cannabis board become the body that sort of oversees this versus trying to create another government or another government agency, if you will?
I think that sounds like a fine idea to not create new bureaucracy, but repurpose existing. I like that idea. And again, this is just my personal thoughts. I'll be voting on this bill just like you will. I'm just giving you my opinions. That's all.
Follow up.
If I could also, in regards to following up with Representative Weber, I do think the use of it in a clinical setting makes a lot of sense. But to follow up on Representative Weber's comment is the legality of it, is that if you get into a clinic, whether it's prescribed or through a drug order, you run into the same issue where a licensed provider really can't order the product through their licensure, if you will. So it does cause a problem, but I think the intent of having some supervision of the patient makes a lot of sense. Would you believe?
I would believe that. I mentioned, I may not be able to pull it up here quickly, but there are experts out there who are working on this issue and working on state legislation. I mentioned the organization MAPS, M-A-P-S. I can't pull up their website right now, but they would be able to answer those questions that you have, I'm sure.
Other questions? Representative McKay.
Thank you, Mr. Chairman. You probably can't answer this question. The implication of this legislation is that this is a therapeutic, useful approach particularly to mental health. Do you know what that's based on? Who did the research and any publications that could verify? My day was that this was a terrible, one of my fellow students at Tufts became quite famous for his use of that.
Was it Timothy Leary? Was that your student?
Right. That So that I'm curious as to how this is full of legal protections and what police can do and can't do, but that I don't see any information as to how they arrived at the assumption that this is therapeutic.
Thank you for the question. I'm not a clinical, scientist. I'm a substitute for the presenter of this bill. So I found the website for MAPS. It's maps.org, maps.org. There's a lot of information there. One thing I do know, our state is on the border of Canada, and Canada has legalized psychedelic drugs. There's a whole industry of you can purchase their stock on the Canadian stock market if you want. There's a whole industry of drug companies who have these novel psychedelic drugs that are being approved in Canada for the purposes that we're talking about. So it's not a far-fetched idea. And there's at least a dozen companies in Canada. That's just based on my knowledge bank.
Another question, Representative Shapiro.
This is a question of the chair. Do we have other people scheduled to testify that might be able to respond to more of the technical aspects to the bill?
No one else has submitted a pink card, no.
Okay, thank you.
I bid you adieu. Thank you.
Thank you. No one has indicated a preference on the blue sheet either. Okay. Sure, absolutely. Bill Bright has signed up to speak from the New Hampshire State Police on HB 1693. Put your microphone.
Yep.
There you go.
Good afternoon. Thank you for hearing my testimony. As you stated, my name is Bill Bright. I'm with the New Hampshire State Police. I'm the major of the Investigative Services Bureau. I just wanted to speak up on this bill. I've read through it once a while back. My understanding is that this would allow for the use of psychedelics not only in a clinical setting but outside of a clinical setting. That raises some public safety concerns for us, as in psychedelics are known, the reactions to psychedelics are known to be unpredictable. Nobody knows how they're going to react to them until they start using them, which is very concerning. Even you could get a different reaction a different time that you use a psychedelic drug. As in, if you took it in a clinical setting, had one reaction, you may not react the same way the next time that you take a similar dose. That's obviously concerning for many different reasons. The concerns would be access to juveniles, underage people, the safety on our roads with the unpredictable reactions to these drugs. Would bring a lot of concerns, as well as just whoever comes into contact with somebody having a bad reaction to these drugs, there would be some safety concerns with that. So those were the things that I just wanted to bring up, is that I believe, after reading through the bill, I believe that this allows for the use of psychedelics outside of a clinical setting, which is not exactly what it sounded like when they testified previously.
Representative Weber.
Thank you for your testimony, and thank you for taking my question. Do you know, if you know, what are the laws in the states surrounding us, the other New England states, on the use of psychedelics?
I'm not familiar with the other states.
I'll
Sorry
have to
about
do
that.
my own research. Thank you.
It is a Schedule I drug, so
Right.
I imagine that it's very similar to New Hampshire everywhere.
Representative Leon, and then Representative Shapiro.
Thank you, Mr. Chairman, and thank you very much for being here. It's good to see you again. My question would be, if we were to refer this to interim study to try to figure out how to enable places like some of the hospitals to our south that have established programs for Massachusetts residents to use it, or the VA to do that, would you be willing to collaborate with us if we were to interim study this and try and make sure that we don't trigger any law enforcement concerns while trying to see that there may be an access for some well-controlled clinical work with some of these underserved communities?
Yeah, we're certainly willing to be accessible for consultation and to collaborate. I can't guarantee that we're going to recommend at any point that we would encourage legalization of psychedelics.
Thank you.
Representative Shapiro.
Thank you, Mr. Chairman. You may be the expert on this bill. You're certainly a few steps ahead of me because I haven't read the whole thing. Do you know where in the bill it talks about what a clinical setting would look like?
Like I
Does
said,
it-
it's been a while since I read it because I believe I read it back when it was coming to us for the fiscal impact. So it's been a while since I've been through it, but my recollection then was that it talked about psychedelics in a clinical setting and outside of a clinical setting. Some of the language right at the beginning. A qualifying patient shall not be subject to arrest by state or local law enforcement, prosecution, or penalty under state or municipal law, be in violation of RSA 318B, or denied any right or privilege for the therapeutic use of psychedelics in accordance with this chapter.
What page are you on, sir?
It's page 4. Yeah. If the qualifying patient possesses an amount of psychedelics that does not exceed the following, and it lists up to 2 ounces. So that's suggesting that law enforcement would come in contact with a person in possession of psychedelics. And that, to me, says it's outside of a clinical setting, just in that first paragraph.
Thank you.
Representative Merchant.
Thank you, Mr. Chair. And also thank you. Official title is major or?
Yeah, major, sorry about
Thank you,
that.
sir. I share your concern about drug being utilized in the capacity outside of a clinical setting and then creating a problem with public safety. Are you aware of any test that can be taken or administered to a patient or to a individual that you think is under the influence of this drug to document, in fact, there is a correlation between, like we do with alcohol, that they're over a certain limit?
So we have drug recognition experts. They're trained individuals within our agency and many law enforcement agencies throughout the state that are able to evaluate people under the influence of of narcotics, and they can usually label they can say they're under the influence of a narcotic or an opioid or a psychedelic, potentially, based on how their body reacts or what they're seeing during the evaluation. I'm not an expert, so I can't necessarily give you the exact terms that are used, but I'm not aware of anything that would allow anyone to gauge the level that they are impaired, the level of that would be in their system. We can tell when somebody is impaired, but beyond that, that's difficult to determine.
Follow up.
So I understand it correctly. It's observational.
Yes.
Not, okay, thank you.
Representative McLean, did you have your hand up earlier?
Yes, thank you, Mr. Chair.
Sorry.
There was testimony earlier that these substances have been approved for recreational use in Canada, so definitely, I think, outside of a clinical setting. Are you aware of any concerns raised, by law enforcement in Canada, any issues that have followed from that legalization?
I have not collaborated with anybody in any Canadian authorities to determine that. So I don't have any specific information on that. I imagine there's similar concerns with public safety at times due to that drug.
Representative Leon.
Thank you, Mr. Chairman, and thank you, Major, for taking another question. Does there need to be a certain per se level of intoxication of any substance in order for somebody to be arrested and convicted of driving under the influence?
Impairment to any degree, I believe, is the term that is used. So that's an evaluation, and then can be followed up with chemical tests later on. But impairment to any degree is the term that is used.
Follow up.
Follow up.
And then as a follow-up, you don't need any actual tested level in order to obtain a conviction. Would that be correct?
Are you talking for alcohol or?
For any of the drugs, considering that I assume that we're arresting people for DUI of all sorts of substances.
Yes, it's impairment to any degree. If the evidence shows that a person is impaired while they're driving a motor vehicle, then yes, you can secure a conviction that way.
Thank you.
Representative McLean.
And just to follow up on that question, the impairment is determined through a field sobriety test or something of that nature? Or how is that determined?
Yeah, it starts with field sobriety tests, and then, as I said, we have drug recognition experts, and that goes further than the normal roadside field sobriety tests. That somebody has to agree to that testing and agree to the evaluation by a drug recognition expert, just like they would agree to have their blood drawn for chemical testing. Anybody can refuse that evaluation.
Other questions? Seeing none. Okay, thank you.
Thank you.
No one else has signed up to testify on HB 1693. Does anyone else wish to testify? Seeing no one, I'm going to close the public hearing on
Oh, I have the online data.
Okay.
There were 6 people who signed in support, 3 that opposed, and 1 that were neutral online.
And no one indicated any preferences on the blue sheet in the back. So I'm going to close the public hearing on HB 1693 and open the public hearing on HB 16, well, maybe by 1 minute.
Let's wait a minute.
1 minute. Okay. In 1 minute, we will open the next public hearing.
Do you mind if I ask Lucy if we have time?
Sure.
My search says it's not legal in Canada. It is decriminalized in some cities. But recreational use doesn't seem to enter into it.
Setting, it's the same thing. You can't really have a provider in a hospital that prescribe cannabis because it's still Schedule 1 federal law basically says you're not supposed to use it. So it's going to be hard to use products in clinical settings because you're bound by federal law that says the provider can't prescribe it, but if the dispenser can't dispense it.
And the point is getting this has to be scheduled. Yes. So that a provider can use it under appropriate.
MGH is actually doing it now. My question is,
I don't have problems with studies as long as I'm not persecuting the study.
I just know it happens.
I think it's merit there.
Yeah, I wouldn't.
Then if we have time, I think we're good for this one.
There's only 10 copies of testimony for HB 1585.
It's not testimony, it's a recommended amendment.
Here, I'll make copies.
Okay, I'd like to open the public hearing at this time on HB 1585 and Representative, how do I pronounce your last name? Grody or Grote?
Grota.
Grota, okay, thank you. Recognize Representative Grota as the prime sponsor. Welcome.
Thank you. My name is Jackie Grota. I'm a state representative representing Rockingham 24, the towns of Rye and Greenland. I submitted this bill with the hopes that this would help assisted living facilities with medication distribution. And we're trying to use the same model that LNAs use to become an MNA. However, during the conversations with several stakeholders, it appears that the bill as written does not address the concern or the request. And meeting with them at least twice, we all decided that a study committee might be the best way to handle this issue. So, for example, in assisted living facilities, individuals who have capability to take their own medication can do so on their own. But if they have an issue with taking the cap off the bottle, or if they have tremors and they need help with a glass of water, there is only a nurse or an LNA can help them. A personal care assistant, which knows this person closely because they work with them every day, cannot help them because it's not part of the rules. So originally we had thought that if we exempted these facilities from this requirement, similar to what we do with DD facilities, it would be helpful. However, it's not so easy because oftentimes these residential care facilities as they're called, have different levels of care. So it's not a clear cut decision. So we all together as a group put together this recommendation for a study committee that we're hoping you'll adopt so that we can be helpful to the community. There are people here who can speak to their situation and the problem at hand, but I'll take any questions that the committee might have.
Okay, thank you. Representative Weber.
Thank you, Mr. Chairman, and thank you for taking my question. Is it also true that one of the moving parties behind this legislation was county nursing homes, and that the regulations get more complicated as the capacity of the patient gets less?
That's right.
Okay.
That's right.
So that would be one of the things that would be studied. Would it be the levels of care?
It would be the levels of care, and the rules that apply to these levels of care are also a bit complicated and could use some teasing out.
Thank you.
Representative Merchant.
Thank you, Mr. Chair, but this is probably a question for our parliamentarian. What's really the difference between an interim study versus a study committee? In a sense that if we create an interim study, we still have a committee getting together to study it, versus if we create another committee. I'm just trying to understand the
It's a matter of timing.
timing.
We could actually refer the bill to interim study, and if people are willing to study it, then they can certainly do that. And a report would be done by the end of, whenever our deadlines are. They're in the calendar. I just don't remember. It's October, and published in the House Journal. There's no further action taken on the bill because we're at the end of the legislative session. With respect to a study committee, that would report, and traditionally they report about November. And again, they would make a report that would not go in the House calendar because it's just a report. And then anybody who wants to file in either case, anybody who wants to file legislation next time around gets to do that. So, I mean,
If
we
I might
can
add-
debate endlessly between study committees and interim study, but.
If I might add, the document that I sent to you, it's a recommended amendment. It's only a starting point, but I do include all the stakeholders that have been involved with the discussion so far, and that has been very beneficial.
Can I?
Sure. Representative Weber.
So if I could go further into the structure of something, if we name all of these people, it's a commission, not a study committee. And that does get into the problem of getting it together and all of our rules about commissions. The other thing that I think is very relevant in this is if it's interim study, it's only members of this committee that are studying it. If we do a legislative study committee, then we can bring in folks from Health and Human Services, from ED&A, which deals with licensing, and perhaps Commerce, which deals with insurance. And that might be a more effective way of looking at it. And if we then, it appears to me, I haven't been able to read all of this, but if you have 3 House members and 2 Senate members, and the Senate will reduce that to 1, you could set up that committee with the recommendation that they consult with, including but not limited to, the people who have already expressed an interest.
Thank you.
Thank you for the indulgence, Mr. Chair.
Sure. Representative Leon, you had some information.
Yes, thank you, Mr. Chairman. The interim study reports are due October 25th, which is 1 week exactly before the deadline in the proposed special subcommittee.
Right. So I didn't ask for an interim study. This is actually for a committee, a study committee, because I felt that members of the ED&A committee would be important to have. And I would offer myself to that study committee to help set the ground for this.
Other questions? Other comments? Okay, thank you.
Thank you.
Also signed up to speak is Gary Cahoon from New Hampshire Arch. Yes. Okay. Sure, okay. Sarah Nadeau from Carriage Hill Assisted Living.
Can you press the button, please? Mr. Chairman and members of the committee, I thank you for the opportunity to speak today. My
We
name
have
is,
a little flexibility in our schedule, so usually we ask people to keep it to 3 minutes. I can give you more than that, but try to keep it under the 10 though.
absolutely, thank you. So my name is Sarah Nadeau, and I'm the owner and the administrator of Carriage Hill Assisted Living. We're a 24-bed facility in Madbury, and this bill is something that has come to fruition through several meetings starting last July. I also am the secretary of New Hampshire Arch, the Association of Residential Care Homes, and we had the opportunity to work with DHHS to do a rules review over the summer, and much of this came forth from a review of those rules. The area of the largest concern and areas was medication administration. And so this bill is to look at those rules specifically only for HEP 804 and HEP 805 assisted living residences. So this would not affect nursing homes, only HEP 804 and 805. We are residential care homes. We are the home of our residents. And the goal is always to keep people in a residential care setting as opposed to nursing home or hospital level care to the fullest extent possible. The concern is that the current rules through the Board of Nursing that licenses staff who are permitted to pass medication have to cover multiple settings, hospitals, nursing homes, and residential care. And they are absolutely appropriately more restrictive given that those licensures do have opportunity to work in those different settings. So where it would be inappropriate, in my opinion, for an LNA to pass medication in a hospital, I do feel that with appropriate training, we are a residential care setting and the rules should be somewhat different for us as opposed to hospitals or nursing homes because they do deal with a higher level of acuity. Currently, the staff who are permitted by law and rule to administer medication in our setting are only RN, LPN, or MNAs. MNAs are medication nursing assistants. So they are LNAs who have gone for additional training for a certification. And then they have a secondary license called a medication nursing assistant license. The concern is that we have a significant workforce staffing issue. And while it affects all levels of employment, all career paths within our organizations, one of the areas hardest hit is those who are able to pass medication. The RNs, LPNs, and MNAs, that is where a majority of our facilities have struggled the most with staffing. In the last 5-ish years, 14 homes have closed in New Hampshire, with the primary reason being a shortage of staffing. And at the end of the day, it is really a patient safety issue. We need to have enough staffing and appropriately trained staffing to make sure we are safely administering medication. But there are significant barriers within the rules, as Representative Grota said, as far as our ability to even assist people to take off the caps of bottles to take their medication. But those barriers to there are also barriers to training. To be an LNA, or once you obtain your LNA license, which has a cost to obtain that training, current rules require the LNA to work for 2 years full time before they can apply to take the medication nursing assistant class. A lot of our population is transient, meaning they do not stay long term. And by that, it's not negative. I have some of my best staff are high schoolers who came out of VOTEC programs who obtained their LNA license. They have broader career paths. Many of them are college bound and are only working for us to gain experience while they're in high school or in college. We also have a lot of nursing students. And so to spend the time and the money to obtain a licensure when they're on a higher level career path does not make sense for them. But they may work, for example, my organization for 3 to 5 years. And during that time, I feel they are very appropriate to be eligible for that medication administration training. But do not have the time or the money and the resources on top of further education to invest in that while they're simultaneously pursuing advanced degrees. So while that may not be all of the staff involved in this, those barriers and time constraints and cost of getting the additional licenses takes a significant pool of the workforce that would be very capable with training to administer medication. It is problematic and they're not able to do that. So part of what we're looking at with this is to remove some of the barriers to receive the appropriate training. Having said that, I think study is the best path forward because we've been meeting on this. Many of the stakeholders and noted as part of the recommended folks to be part of this committee. We all recognize that this is a problem, that there are safety concerns. I am very optimistic with us meeting that we all have a fundamental belief that this is a significant problem with the aging New Hampshire population, the shortage of workforce staffing, limited number of nursing home beds, that we have to address this issue to keep people appropriate at the most appropriate level of care. But the barriers to them obtaining their proper training and certification is problematic. So I am very much in favor of this bill. I'm optimistic that with those stakeholders, we can come up with a solution that everyone is comfortable with and we can put forth a solid bill next year.
Okay, thank you. Representative Shapiro.
Thank you, Mr. Chair. I understand you're recommending that it go to a study committee, but going back to the original bill, and you gave quite a few reasons why it hasn't worked to depend on I don't remember the acronym, but medication is medication.
The M&A?
M&A.
M&A, yes.
Medication
Nursing
nursing
assistants, yes.
But would the LNAs who were able to administer these medications or help people take their medications, would they receive some lesser but still some kind of training that went beyond the regular LNA?
So if I'm understanding your question correctly, I just want to make sure I'm understanding what you're getting to. So the LNAs, primarily their role in our facilities to help with grooming, toileting, dressing, and so forth. They are not currently permitted to administer medication other than to a particular cohort if they are able to accept nurse delegation and receive appropriate training. So there is a potential for them to receive nurse delegation and pass medication, but they cannot pass to the entire building. So it doesn't necessarily help with our staffing situation, in the sense that if you have to have an RN or an LPN also on site at the same time, even if they're assisting through nurse delegation. So to answer your question, if I'm trying to get to it correctly, so the LNAs do a different role than those passing medication. So the LNA would have to go for further education to get that M&A license on top of their LNA license to be able to administer medication. So we have several options that we need to explore to determine how best to move forward with that training, whether it is reducing the time requirement before they can take the M&A, or are we going to look at a different path where an LNA track is different than an M&A track and they can choose either career path? I'm not sure what the ultimate recommendation would be, but that's why we need to take it further to study. Did that answer your question, sir?
Follow up.
Okay.
I can see why it needs further study.
Yeah, it is complicated, yes.
Representative Merchant.
Yeah, thank you, Mr. Chair. This is probably more a question to the chair than to the person testifying. I see that this is really important. If we go through a study committee, if I understand the legislative calendar, this is going to be a report that comes out sometime in October, November. Then we have to have legislation again next fall, work on it next winter, and hopefully get something to law maybe by the summer of 2025. Is there any possibility, if this is not an early bill, to have a subcommittee to come together and try to work on this? This is not an early bill, so I mean, if we have time, we're trying to get to, in order to try to meet the calendar this time and get something in place by the summer or the fall, is having people in the subcommittee meeting with the stakeholders and try to draft something that may make sense versus waiting a whole year.
This is not an early bill from what I Right, so we'd have until what, March 15th, I think? March 14th? I think is the deadline,
To report by March 21st.
March 21st, so we have a month and a half or so.
I thought it was early, Bill.
I don't think it is.
No, this is not an early bill.
So I guess it would be the call of the chair, again, also by the stakeholders, whether there'd be enough interest in trying to work on this during that period of time to come up with an amendment to the bill to make something viable.
I
that
take
we
it
could-
you're volunteering for a subcommittee? You
I
come up
will
with the
volunteer
ideas.
for a subcommittee, yes.
Okay.
If the
Representative Weber?
stakeholders are there.
So I'm looking again at the original bill, and I'm not understanding why this administration is already allowed, it's already in statute, for people who are caring for people in the community. And so I'm wondering why it's so difficult to have it also exist in in care facilities where there is more supervision rather than less supervision. That seems counterintuitive to me, and I was hoping you could just help me with that underlying issue, because it seems to me that there's more supervision available and therefore less risk of something going horribly wrong in the residential setting rather than in the community setting.
So in having met the last 2 weeks with some of the stakeholders, I think the concern is that many of us, based on the acuity of care of our residents, we do go through end of life. So you do have people who are in hospice at end of life who are physically unable, cognitively unable at end of life to take their own medication. So we do have a significant higher acuity of residents than the DD homes, which are the ones that we were hoping to be exempted with, similar to the DD homes. So there was a concern about the acuity of our residents compared to the residents of a DD home. And also, there are some complications with the current rules through the Board of Nursing. So for us to implement some of this, it would affect Board of Nursing rules, which would affect licensure of the staff that work for us. So if we are exempted, and I may not be representing this completely, but my understanding is if you exempt us, it does create some concerns about our staff who are LNAs. How does that affect their licensure? Because when you hold that license, you are held to those rules. So unless we also modify Board of Nursing rules, they cannot work outside of the scope of their practice. So there are still concerns about them being in violation of their licensure because they are still required to follow Board of Nursing rules. So that's where you get some complication in the overlap between current Board of Nursing rules, which govern their licensure, as opposed to just trying to exempt us. We still have staff that have to follow their licensure requirements. Does that help address that concern?
Follow up, Representative Weber.
Well, here's my problem. The bill as it was drafted, as opposed to as you have been discussing it going forward, and I understand all of the reasons you're wound up in the Board of Nursing rules, but the bill as drafted is working off of what appears to me to be an existing statute that talks about the administration of medications by any person employed or under contract to provide direct care to clients receiving community-based services. And so presumably this is already happening in the community. And if so, either they have gotten around, it is, I was assuming as I read it that we were talking about people who were not LNAs. And so.
Yes, so correct. So the original bill was drafted to allow unlicensed staff to take a separate training program, in a nutshell, somewhat equivalent to the current M&A certification course. But having said that, how does that affect our LNA staff, who are a large percentage of our staff, they still would be unable to administer medication. So if it were to go forward as currently drafted, it would allow unlicensed staff to potentially obtain that additional training, but it does not solve the problem that a majority of our staff are LNAs and they would still be unable to administer medication. So it would help with some of the workforce staffing issues and the safety issues, but it didn't resolve it fully enough for us to feel comfortable that that was the best path forward.
Follow up.
So my last follow-up is, what would be the harm of passing this bill as it is drafted so we can address part of the problem and then allow people to come in with the other legislation going forward that will address the issue of the LNAs and all of those issues of having to wait 2 entire years before you take the medication training? What's the harm of passing it as it is and then allowing that to come afterwards?
No, I would say that that would be an acceptable approach as well. And then I do think there would be definitely interest in pursuing further so that we're addressing it for all of the staff that it would apply to. But I agree with what you're saying. I hear what you're saying, and we're not opposed to that. I think we were looking for a more comprehensive solution all at once, but I understand that, yes, it would help with some of the current staffing needs, and then we could come back and address it further.
Representative Merchant.
As follow-up onto my volunteerism, instead of a subcommittee, is it possible to have an ad hoc committee? Therefore, we could have people meet via Zoom. If there's interested parties, no, we cannot do that.
The rules don't allow it.
Even as an ad hoc committee?
It's an official
There's no-
body of the House, no. Sorry. Representative Cushman.
Thank you, Mr. Chairman. Thank you for being here, and I appreciate this legislation very much as a nurse. And I occasionally work in assisted living facilities, so I understand this need. But as I'm reading this bill here, I don't see that it, as it's written now, I see that it exempts even LNAs who otherwise under the Nurse Practice Act are required to work for 2 years and then, get that medication administration certification. This exempts any person employed or under contract who's giving direct care to clients in these facilities, as written now. So then if we made that change, then if there was any conflict with the rules that are in place, that would trigger the department to have to go back and bring the rules into compliance with the law. So as I see it now, it looks like this bill does exactly what you want it to do. Do you see what I'm seeing?
I understand what you're saying. There definitely would be some conflicts for the currently licensed staff, but I understand what you're saying. If it did require it then to subsequently require those rules to be reviewed, that would be agreeable.
Other questions? Seeing none. Thank you.
Okay, thank you very much.
Okay, Gary Cahoon, New Hampshire Arch.
Mr. Chair, members of the committee, thank you for the opportunity to address you on House Bill 1585. My name is Gary Cahoon. I live in Peterborough. I am an advisory board member of New Hampshire Arch. I'm an advisory board member because I'm retired, so I can no longer be a full member of the board. For 37 years, my wife and I ran Friendship Manor, which was a 22-bed residential care / assisted living home in New Ipswich. We were forced to close Friendship Manor in May of 2022 because we could not hire enough staff to keep operating. So this question, at least tangentially, was an issue in our closure. Excuse me. My role with New Hampshire Arch over the years, and I've been a member of New Hampshire Arch for more than 30 years, and I've been on the board for most of the last 30 years. but I've always been involved with legislation. I was either the vice president for legislation or chair of the legislation committee. And my first interface with the legislature, with the House, was in 1994. There was a study committee in 1994 to determine what the rates should be, the reimbursement rate should be for residential care. The reason there was a need for a committee was because the rates had been frozen for 7 years and people were going out of business. But one of the things that committee did was to look into all of the factors that were affecting residential care and what the cost factors were. And one of the big areas of concern was medication administration. And at that time, that subcommittee looked into the system which is used in the DD and the mental health community residences and said, this sounds like a good thing. But the committee decided that its principal and priority was rates. So they made a recommendation with regard to rates in the form of a bill, but said we'll take up the medication administration in the future. There was an effort over the next couple of years to do something about medication administration. There was a proposal for a pilot program, but basically those efforts failed due to opposition from the Board of Nursing and the New Hampshire Nurses Association. So that was not the time. But I think we're long past time. There was a story that I told in that study committee years ago. I had a resident whose name was Don. Don had Parkinson's disease and had a notable tremor in both hands. He also had glaucoma and had to take eye drops daily. And legally, we couldn't help him in any significant way with his eye drops. Okay, we were told that, well, you can do it hand over hand. In other words, he can hold the bottle, you can put your hand over his, and together you can squeeze the bottle, but he has to be the principal squeezer of the bottle. And we would have tried that, and the drop would hit him in the nose, roll down his nose, and fall onto the floor. So there's been a problem for a long time. And I agree with Representative Weber, it doesn't seem like it should be that complicated. But I think it's perhaps time, the time is right, because now there is a consensus among all the stakeholders that something needs to be done. So I just urge us after 30 years to get this done. Thank you.
Thank you. Representative Weber.
So is getting it done, in your opinion, passing the bill as it is, or is getting it done changing the bill into a study committee?
I don't like the idea of a study committee because I'd like it to be done more quickly than that. So Representative Merchant's suggestion that a subcommittee could be formed might be helpful. One of the issues, and I'm not as conversant with this topic as Sarah is, but one of the issues with just passing the bill as it is comes around HEM 1201, which are the rules that apply to community residences. And the question is, should those rules apply to residential care homes? Are they wholly appropriate to residential care homes? Or could something else, perhaps less restrictive, be done? That's just one question that would come to mind. So I think a little bit of study around that would be helpful. But again, I don't want to postpone things as long as the calendar would indicate if we went with a study committee.
Other questions? Seeing no other questions. Thank you.
Thank you.
Also signed up to speak is Doreen Shockley from the Department of Health and Human Services. You don't indicate an amount of time. How much time do you think you're looking for here? 3 minutes, okay? Okay.
I always forget. There we go. Now it's on. Good afternoon, committee members. I am Doreen Shockley. I am the manager of the Bureau of Licensing and Certification at the Department of Health and Human Services. I was not intending on speaking today, and I hope that I will be very brief. I wanted to clarify some items that have come up a few times. The department, part of the Bureau of Licensing and Certification is our adult licensing unit. Kelly Keefe is the unit chief of that unit, has been actively involved with Sarah and her colleagues in terms of changing the rules. and we have worked very closely with the sponsors on this bill. We have also met regularly with the Ombudsman's office, who's here. We've met with the OPLC. The Board of Nursing has been invited to these sessions. We all agree that this is a very important topic and things need to happen. However, the way the bill is written now doesn't completely solve the issue. And as we were going, as we were going through a lot of the meetings, Representative McGuire is also present, and one of her aides was going to do some research to determine the history on why the community-based services are exempt from, and Representative Weber, you've brought this up a few times, and I just want to clarify the difference. There's a very distinct difference between community-based services and our licensed residential facilities. Community-based services are certified through a community residence unit that I also oversee, and there are no more than 4 individuals living in a home. I could be one of those providers. You could be one of those providers. So then when you get into a residential setting, you have usually more than 16 individuals. There are also, as we were progressing through this conversation, there's layers and layers. There's life safety, there's fire code. So there's it involves many different agencies and many different stakeholders. So we thought that the important thing to do was to pause and to figure out what is the best way to all gather together to make sure that we come up with a bill that covers all of it and keeps the people and the residents that are in these facilities safe. Not all facilities are going to do as Sarah has been well at explaining, so we need to be very careful that the training that these individuals are going to have meets a certain threshold. So again, we all agree that something needs to happen, but going to study, whatever that is called, commission, committee. I've heard a lot of language, and I'm sorry, I'm not as familiar with that as I should be.
Representative Shapiro.
Thank you, Mr. Chairman. I heard you say that you don't think that this language solves the problem. And I also heard you say that we all have to get together to solve this problem, but it seems like you're in a unique position. And I wonder if you could come up with language to solve the problem.
So I would love to be part of the committee that Representative Merchant is going to oversee. And again, we have a lot of interest already within the state Department of Health and Human Services. So I know we are all committed to doing this. So, and I agree with Gary. I mean, the sooner, the better. But it needs to be thoughtful and intentional and solve all of the issues and make sure that we've taken everything into consideration. Because at the end of the day, we want all of our residents to be safe.
Follow up. Thank you. My experience working currently on a few other bills that we're trying to get agreement among people is that even where there's not that much disagreement, is it's difficult. And sometimes if there's a starting point, which you may be uniquely positioned to have, it works, it goes better. And so I don't know what my question is, except that I guess my question is, are you confident that this group of people meeting together for a short amount of time could come up with a solution?
Absolutely.
Okay. Thank you.
Representative Weber.
So, in generating a solution, would you care to comment on my bewilderment here? Because when this issue came to me, and I'm one of the sponsors, it was from my county nursing home administrator, who was very concerned about staffing issues, as everybody else is, and medication administration in the context of our county nursing home. And now, as far as I can tell, the discussion doesn't include county nursing homes at all. And while I wonder how we got from there to here, I'm still left with that question that I've asked everybody else. If this is done in a facility that has more supervision rather than less supervision, because the initial concept had to do with county nursing homes, would that be a problem for the department?
So I'm unaware of any county nursing home that has had this challenge or has brought this to. So I'm happy to have any conversations with that administrator, or perhaps that administrator or other representatives from the county nursing homes should be part of this study or committee, whatever we're calling it. I'm not sure I understand more supervision. When you have a community residence that has 3, maybe 4 residents that are DD or developmentally disabled or acquired brain disorder. I'm sorry, I'm forgetting there's another side of the room here. Those folks have lower acuity needs than in general than an assisted living facility. And I think Sarah articulated that very well. There's different levels, 2 different levels of an assisted living. And then there's the nursing homes, which comprise the bulk of our residential settings. A community residence doesn't fall under that same definition. They are carved out as separate and distinct. So they also have staffing, but oftentimes in a community resident, the staffing is 1-to-1. So the staffing ratio in a community residence is often much higher than that in an assisted living facility. So we're talking about apples and oranges. And I know it's really complex, and for that, I'm sorry. And that's why I think, to Representative Shapiro's question, I think the folks that have already been discussing this, and we're so thankful to the sponsor and the folks that have brought this forward, that they have engaged with us early on. We've been talking about this for months and meeting on it very carefully. You said, and my answer was absolutely. You said in a short period of time. I should have asked for you to define that.
Representative Shapiro.
Thank you, Mr. Chairman. I'm not sure it increases my confidence to know that you've been working on it for months. This is a question for the chair. We've talked about varieties of ways to study this or come to some kind of agreement. Would one way be for just the stakeholders involved and DHHS to continue working on a solution with maybe one member of our committee sitting in with them? Would that be not an official committee, and could that happen by Zoom? And could that be a more informal process, since we have a number of weeks before we have to exec this bill?
That's kind of a unique approach. Representative Weber, do you know of that having been done, or?
Okay, well, let me first say, as the short answer, we need to report this out if we're going to report it out and not have an interim study or a study committee. If we're going to have an actual bill, our last day to report that is March 21st. So that's a drop dead deadline. And you could certainly pursue both options. You know, on the one hand, let's see if we can come to a resolution. And on the other hand, let's have a study committee ready to go if we can't. But it has to get done by March 21st. That's item number 1. Item number 2 is that as long as it is not an official committee or a subcommittee of this House, everybody in the state of New Hampshire has a right to consult with anybody else in the state of New Hampshire as they please. And so any group that wants to get together is welcome to do so, and they're welcome to invite anybody they want to invite.
For whatever means they wish to
For
choose.
whatever means, as long as we're not violating the right to know law, which would mean a majority of this committee, which isn't a political caucus. So you can certainly have meetings with less than a majority of this committee plus anybody else who wants to participate. But we need, for legislative purposes, to have some kind of action on the bill by March 21st, because that's the deadline for our committee to report.
And that's over a month and a half, okay. And so that's very helpful. Thank you, Representative Weber. So if I understand, the sponsor, and we've been meeting for months, but not like weekly or daily. Not that we would meet daily, but we could, in fact, increase the frequency of our meetings, I think. And then if we were to come up with language that makes sense, even short term and then long term, something else, as long as the sponsor has something to you by the March 21st date, then
Well, we'd want it before that.
We'd like
mean,
it
before
before
that,
that,
yeah, okay.
because
Yes,
bear in mind that we also, if I may, Mr. Chair, have to get it through OLS, which is legislative drafting. We're not allowed as a committee to vote on something that looks like this. We have to take it to legislative services and get them to draft, and they are serving 424 of us.
It would be, well, it was going to be kind of an informal effort. It could be as simple as just deferring any executive session action until March.
Yeah, we could do that,
Yeah.
certainly.
so I clearly can't speak for the sponsor or all the stakeholders, but I thank you for this information. I've never, in all the years I've been doing this, had this type of situation arise. So I appreciate the flexibility and the opportunity to continue working together to see if we can come up with a combined solution, even if that's short term and long term.
Representative Merchant.
Thank you, Mr. Chair. Also, I don't think we have to get it exactly correct. This is going to go to the other chamber. So if we're close, we can then continue the process, or the chamber on the other side could continue the process to fine tune it to make it exactly what people want. So wanted to let people know that we do have more than March 21st for the House, but we still have time on the other side of the wall.
Perfect. Thank you.
Anyone else? Representative Kofalt.
Might I suggest that we specify when we would need it, because right now we know that it's sometime before March 21st, but if we allow time for redrafting and for additional hearing, discussion, and exec, what date would we like for there to be a proposal of some kind in hand?
Yeah, the week of the 5th or the week of the 12th of March. And again, we usually been doing this on Wednesdays. So what, the 7th or the, 14th is really pushing it.
Those are the Wednesdays. Oh,
So
sorry,
re-
those are the Tuesdays. The 6th or the 13th of March would be a good date. The 6th. Let's aim for the 6th on all of these.
6th, okay.
Okay, so March 6th.
Sharpens the mind to have a deadline.
Have a work session. We'll figure out.
So just to be clear, we're proposing that anybody who wants to bring a proposed amendment would have the parameters for that proposed amendment by the 6th, so that it could then be sent to OLS, and we could discuss it here, have a hearing and an exec session on the 13th.
The 6th, right? Didn't we say the 6th?
Yeah. So the thought would be, there's probably going to be several bills, some that we have subcommittees, some that we just informally have people working on. And it would be good to ideally shoot for the 6th if we can for any of these, so we can discuss them and see if there's further work that.
For
further
hearing and
questions.
exec.
For a work session potentially.
Yeah, I think we would have to notice them for a work session on the 6th, and that gives us the ability to discuss among ourselves which direction we're going in as a committee.
Okay, and I guess I'm suggesting that we back it out a couple of days for OLS to draft something so that we have something clear to look at. So I'm just, I guess if I walk it backwards, I'm looking at Friday the 1st of March as a possibility.
Representative Weber?
I thought that the point of the 6th was you could discuss it on the 6th and then send anything to OLS, which would give us drafts for the 13th, which would keep us well within our timeframes.
Exactly.
And give you the maximum amount of time to get it done. And that's why I was suggesting that we notice the 6th as a work session, so we can take it up and either put it down or just send something to OLS and exec it the next week.
Representative McLean.
So does that mean DHHS and ARCH they go off, they meet, and they bring their material in on the 6th. Okay.
Anyone else? Okay, thank you.
Thank you.
Also signed up to speak on this bill is Susan Buxton.
Good afternoon. My name is Susan Buxton. I'm the State Long-Term Care Ombudsman. Thank you for allowing me to speak. I, as Doreen said, was not prepared to speak today, but it sounds like, given this last comment, I would agree with that plan. As Doreen had talked about, I also served on some of the meetings, and I believe at the end of the time, which, you know, was just a couple of weeks ago, we really had identified there were a couple of things in this bill that created some problems. One of them was the reference to RSA 151, which includes nursing homes, and there would be conflict created if this bill were to pass as written with the regulations that oversee the nursing homes. And so we need to really be clear about which level of care we're talking about. I think the other concern is we really need to fold in the Board of Nursing and not create a whole separate system of individuals that are providing service in long-term care. And before one of the other committees in the House is the question of certification versus registration of nursing assistants. And I think there is a plan to continue to work on that. And I think these two bills do dovetail because we're now talking about creating a whole separate subset of individuals that are going to work in long-term care. And within the residential care setting, and I'm sorry I missed some of the earlier testimony, and I know that Sarah probably spoke to the difference between the 804 and the 805 facility. But even within those facilities, there's a tremendous amount of variation between the types of service and the types of individuals and the complexity of their medical conditions that live within those buildings. And I just want to make sure that we are really thoughtful that we're creating a set of laws that takes into account all the different types of settings in which this would cover, and that we're really thoughtful that we're not creating a situation which is unsafe for the individuals that live in those buildings. I'm happy to answer any questions or clarify.
Okay. Representative Leon.
Thank you, Mr. Chairman, and thank you for coming up to offer this insight. Would those conflicts be with statutes or with rules?
I think it's both.
Okay. Then as a follow-up, if it's possible to get information to us, what laws and which specific sections
Sure.
of the statute would be in conflict, that would help us with the work.
Okay.
Thank you.
Other questions? Seeing none. Thank you.
Thank you.
Okay, I have no one else signed up to speak on HB 1585. On the blue sheet in the back, two people did sign up in favor, and one person signed up just to provide information. And what was the 3 and 2?
Online, it was 3 in favor and 2 opposed.
Okay. So with no one else signed up, I'm going to close the public hearing on HB 1585 and open the public hearing on HB 1568. The prime sponsor, Representative Sellers, I believe, is unable to be here, but Representative Tim McGue is here on his behalf. Welcome, Representative McGue.
Thank you, Mr. Chairman. Good afternoon. I think it's been 22 years since I've been in front of the HHS committee, and the last time was for an ambulance bill also. Some of you might remember EMS was in 151B a long time ago until we put it in 153A. And I think that's the last time I was here, believe it or not. So this bill, excuse me, this bill is meant to help our ambulance providers recoup their costs when they go to a call and provide treatment and use resources and don't have any way to submit for payment unless they transport the patient. So the best example I can give you, and the most common one, and I suspect you might even hear it again from those behind us, is in my 33 years as a paramedic, the typical situation is a diabetic, an unconscious, unresponsive, hypoglycemic diabetic. It's marginally routine for that disease state, or in some cases that you find a diabetic who's just, for some reason, their sugar's gotten out of whack, they didn't eat, they exercised too much, whatever it is, and their loved ones or even they call and you check their sugar, start an IV, provide some intravenous glucose, oxygen, ECG, which are part of the standard of care for that workup. And they wake up and they're fine. They're good as new. Probably everybody here knows somebody like that. And the last thing they really want to do is be loaded into the back of the ambulance and taken to the ER. The last thing the healthcare system wants to do is pay for those two things, especially the second part, which is the ED visit, which will result in typically labs and other sorts of things. So other third-party payers do compensate for this, and you can imagine why they might, because they also would like to avoid that expensive ER visit. So this bill was a request of a constituent of the prime sponsor, Representative Sellers, and I can tell you that it's a great idea. It's a simple fix. I have just learned today that our former division chief or bureau chief, I forget her exact, maybe it was division director, Senator Prentice, she was a chief of EMS, as many of you know, has another bill, Senate Bill 409, which probably should be aligned with this bill. There's some language in that bill that qualify how the services were accessed, like through the 911 system. It's a few good pieces of that bill. So probably both of these should go together. And I think there's probably 10 or 12 or 14 senators co-sponsoring that other bill. So it might be nice if these two agreed when we get it. So I'm sorry, I literally just learned of it a short time ago, so I don't have a proposed amendment for the committee. I would have done that work for you, and I'm happy to do that work for you. But in summary, it's hundreds of dollars, thousands of dollars at the ER that could be easily saved, and it's much better for the patient if they are able to just stay home and the providers are functioning at their level of licensure by allowing that to happen, by allowing them to sign a refusal of transport. And I can talk to the fiscal note too, which actually just came out today. Let me talk to the fiscal note real quick, because maybe that'll answer some other questions. The fiscal note came out today and talks about significant additional expenditure in ambulance reimbursement. That's probably likely, but it would be more than offset by the savings of what is often the current practice, which is put the patient in the ambulance before you do the workup. Now they're still unconscious or semi-conscious, and you've got their implied consent to transport them, and therefore you can generate a bill, right? And that is specifically the message that was told to us, and I say us, myself and my colleagues working for a private ambulance service. Once the hospitals stopped replacing our consumables, our IV setups and our drugs and all that for free, and it started coming out of the private ambulance's pocket, guess what happened? We transported every patient, right? Because that's a billable run. So we're essentially forced to do that to get some reimbursement. And those workups would happen in the back of the ambulance instead of in the patient's living room. So ask yourself which is better. I think we all know the answer. So hopefully that, if you look at the fiscal note, it doesn't account for the offset, the savings offset for ambulance or ER visits that typically would accompany this type of patient.
Okay. Representative Seth King, are you all set? Okay. Representative Weber.
Thank you, Mr. Chair, and thank you for taking my question. So essentially, all we're doing is we are looking at shifting the costs which are now borne by, I'm not aware with the private ambulances, but I certainly am aware about the town ambulances. the costs are currently shouldered by the town entirely because it's the ambulance service. And what this would do would be to avail ourselves of federal remuneration, at least to some degree, so that would offset both the charges on the town and the resultant property taxes. Is that right?
Yeah, that is my understanding. And so every town does it a little bit differently. Some towns don't bill at all for ambulance services to their townspeople. You know, it's sort of part of the services they provide in their taxes. Some bill only if the patient has insurance. Some payer could be Medicare or Medicaid or private insurance. So some don't bill at all, some bill only with insurance. But definitely this would help those towns that are otherwise just bearing the cost of those non-transport treatment sessions. And it's not just for diabetics. There's other possibilities too. So yeah, I believe you're correct. Thank you for the question.
Other questions? Representative Cushman.
Thank you, Mr. Chairman, and thank you for bringing this bill and taking my question. I am wondering about, and I know we've touched on it a little bit, do you have any idea what the cost increase is going to be to towns and companies to have personnel qualified to submit the insurance claims?
Representative Cushman, that's a great question. And the answer is no, I don't really know. But I do know that virtually every town bills in some fashion. They're already set up to submit an invoice when there's a payment source. Not too many towns don't bill at all, like just ignore that part. They file the run sheet and then just don't send anybody a bill. So I suppose that the towns could choose to continue to not submit a bill. I mean, that's their current practice. It's already borne by their tax base, and they might choose to not take advantage of this source of reimbursement.
Follow up.
Thank you. In my town, we will send a bill, but it's just an invoice, and then it's the responsibility of the person, if they have insurance, to then send that to their insurance. But we also have a policy that if the need for services was a result of some negligence, or the person was under the influence and they denied transport, that we send them a bill for that as well. Is there anything in here to kind of set that kind of situation aside and exempt it from this coverage?
No, not in this bill. In 409, it might be, and I'm not sure. I'd have to pull up the text of 409. It's a bit longer, but I don't think there is an either. And I think the department's attorney is behind me, and he can probably answer that question. He's much more familiar with that particular bill.
Other questions? Representative Weber.
So this is a question of the chair in terms of procedure, given that there is another bill in the Senate. Would it not be simpler for us to pass the legislation that we think we ought to pass, send it to the Senate, and then let the Senate change our legislation into their legislation, and then it all comes out in the wash at the end, rather than trying to justify them back and forth?
Certainly.
It's a worthy objective. I'm not sure what the sense of the committee is, but would make sense.
Yeah.
Yeah.
I just was trying to make it simpler on us.
Sure.
Sure. Yeah.
Other questions? Representative Merchant, did you have your hand up a moment ago?
More of an inquiry. Thank you, Mr. Chair. And thank you for taking the question. In the community that I reside, there's a frequent number of 911 responses. And a lot of it is sort of what I call false responses. And what triggers it is many of the elderly have devices and actually have things on your Apple Watch now if you fall and so forth, and it triggers a response. But there really is no medical emergency to it. So how do we break that apart from somebody who's truly like a diabetic and needs a medical response, but it wasn't something triggered by technology, triggered by something that was sort of what I call a false alarm?
Yeah, great question. Thank you, Representative Merchant, for that. And it's a valid point. We should bring that up because there are a lot of those life call responses. My own parents and others have been through that. That generally doesn't generate treatment or a billable case, a billable patient care record. So, just a lift assist back in, off the floor to the couch and they're fine. There's no workup there. There's no, nobody starting an IV or giving oxygen or anything like that. So that typically wouldn't generate a bill on its own. It's usually just a public service.
Thank you.
Other questions? Seeing none? Thank you. Also signed up to speak are Rob Barry and David Chorney from the Department of Health and Human Services.
Good afternoon, Mr. Chair, members of the committee. My name is Rob Berry. I'm General Counsel to the Division of Medicaid for the New Hampshire Department of Health and Human Services. And with me is...
Good afternoon, David Chorney, Deputy Medicaid Director.
So we are supportive of this bill. We've provided similar testimony at SB 409, which was mentioned earlier. We were going to suggest that the two bills do align, as SB 409 does have some parameters in there that we think is helpful for the department in terms of determining how a service would be reimbursable. Also, there is some contingency language in SB 409, I believe, that was just added this morning through an executive session that would make the bill contingent upon approval from CMS. So other than that, I'm happy to take any questions you may have.
Thank you. Any questions? Seeing none. Okay, thank you. Representative Shapiro, could you check the blue sheet for me on this and see if there's anyone on there, or perhaps bring it up? And Representative Valet, on who signed up online?
Online, there were 36 in support, 1 opposed, and 1 neutral.
People definitely like the online process better. One person signed up in favor of 1568 on the blue sheet. Does anyone else wish to testify on HB 1568? Seeing no one, I'm going to close the public hearing on HB 1568 and open the public hearing on HB 1010 and recognize the prime sponsor, Representative Leah Cushman. We don't have a pink card.
No, not for me.
That went out for her.
Okay.
Unfortunately, won't be able to be your timer.
Oh, that's okay. That's fine. I can do it.
And here on this one, I'll ask.
Good afternoon, Representative Cushman.
Good afternoon. Thank you, Mr. Chairman. Thank you, members of the committee. I am before you today. Well, for the record, my name is Leah Cushman. I represent the town of Ware, and I bring you today HB 1010 relative to expanding maternity options and midwifery access. So I'll start with just a little bit of background on what midwifery is. The practice of midwifery under the statute that we have that governs it here in New Hampshire which is 326-D. It's acting autonomously, providing supervision, care, and advice as appropriate to a client.
Representative Cushman, could I just interrupt you for a moment? Representative Weber, you have a question?
We seem to have lost control of our handouts, but we have, these have stopped.
There's another one here.
Are there more of these?
I didn't divide them, no.
Okay, but I don't have any and the clerk doesn't have any. And the clerk really.
Oh, odd. Did they stop at my side on that side? In my seat?
Good now.
Okay, I didn't get the second one.
I've got both.
Oh, yeah, that one.
I apologize. I asked them to print 20 of each, but
I don't have that one.
I think that one's going that way.
Thank you. Is everyone else set now?
I don't have this one.
You can have that. No, I have two.
Everyone all set now? Okay, thank you. Sorry.
Sure, no
Representative.
worries.
Continue.
So under their scope of care, this statute, it's the administrative rules that govern midwifery are created by a midwifery council, which is made up of 3 New Hampshire midwives and an OBGYN and a physician, I believe. And it acts just like the Board of Nursing or the other boards where they vote on their rules. And so under their scope of practice, and the rules are under mid 100 to 500, they provide counseling and education, holistic care, early recognition and prevention of potential health problems, detection of abnormal conditions of the mother, fetus, and newborn, procurement of medical assistance if necessary, and execution of emergency measures in the absence of medical help if necessary, and lactation assistance. They're trained and licensed to provide breast exams, pelvic exams, venipuncture and IV fluid administration, hematocrit and hemoglobin specimen collection, capillary blood collection, Pap testing, cultures, urinalysis, oxygen administration, episiotomies, repair of tears and lacerations, and injections and neonatal resuscitation. So I just giving you a global kind of overview of what midwives are. Now there are certified nurse midwives who are advanced practice registered nurses. As far as I can tell, these rules do not cover them. There's also physician's assistants who can help with birth, and they may have some certifications in that area as well. And then we have your OBGYNs, which is a different scope of practice. So the council handles the certifications, complaints regarding licenses, scope of practice, continuing education, and the like. There are a small number of midwives in New Hampshire, but it is a growing industry as demand increases. So there are some things that the rules in mid 500 specifically require that a midwifery terminate the care relationship with the mom for. It's there to protect the mom's safety, and a lot of it is, based on a study. Well, I'll get to that. Sorry. It seems like there's a difficult process to have an amendment made to those rules. You can petition a rule change in writing and satisfy written explanations of what I think it calls what it calls for, and then they send you a decision and an explanation. But I don't think that the majority of patients, mothers who are pregnant, know how to go about asking for these changes. And I happen to be plugged into communities where a lot of these moms who would rather have a home birth are, and I hear from them all the time, their complaints about their access to midwifery care. So that's why I brought this bill forward as a representative. I'm bringing it on behalf of the people. Midwifery is not a novel practice, and the purpose statement of RSA 32060 says, it explains clearly that women are going to choose home birth, and they're at increasing rates. And if they're going to, we should allow them to have help available. Many women right now are precluded from midwifery care for the reasons listed in the bill. which I will expound on. And they would rather give birth beside a river alone than go to a hospital and receive care at a hospital. And so if we're concerned about safety of women and infants in home birth, that's a question that we need to ask ourselves. Is it safer to deliver at home with a midwife in a potentially higher risk situation, or is it safer to birth alone? So the conditions that are listed in the bill, the first one is multiples. I'll get to that later. I got questions about, the statistics on the risks. So we'll talk about vaginal births after cesareans. Right now you can have a VBAC. It's called colloquially a VBAC. You can have midwifery care after you've had one, but you can't have midwifery care if you've had two. So this bill just brings it up to you can have one after two. The Northern New England Perinatal Quality Improvement Network, which provides a document and guidelines for health workers, and that document is used to provide informed consent that's required by rules for midwives to do VBACs. They have in their guidelines that the risk for uterine rupture is approximately 0.3 to 0.7% in a person who has had one VBAC. And then the risk for a uterine rupture is likely greater than 7% for 2 prior VBACs. So there is a risk there. Now, how you would determine that risk versus how someone else would look at it can be different. But essentially, there are other things that come into play when we're talking about risk. You could have a person who is completely healthy and has had one cesarean section and has no other risk factors, or you could have someone who has had two and no other risk factors, or you could have someone who's never had a cesarean section but has a lot of other risk factors. So it's like a matrix that you need to consider, and that is something I think that midwives should be able to consider. I think that we talk a lot about not regulating the practice of medicine, not legislating it, and I'm seeing in these rules that there's no other practice that's more regulated than midwifery. I mean, I would be terrified to work as a midwife in New Hampshire because the rules are so cumbersome. I mean, it's almost impossible with the standards of practice for you to, the way I see them, to follow them completely. And there's nothing in there about patients being able to refuse certain things either. So it assumes that patients will just do whatever you say. So that's where the liability comes in. But so midwives are trained in birth work. These are CPM, certified professional midwives. They go to school, accredited school, then they have to have a preceptorship. They get experience. They take courses on laceration repair. And many receive instruction and can even go and be certified on breech delivery, malpresentation of the fetus. That's what the next disqualifier for midwifery care is, malpresentation. So we know that as breech, right? I did pass out a couple of handouts. One is an article from 2019. It's in the Journal of Midwifery Today. It's a literature review. If you look on page 2, it's mentioning the RCOG, which is Canada's version of the American College for Obstetrics and Gynecology. And talking about how they updated their breech guidelines in 2017 and estimated the risk of perinatal mortality during a planned vaginal breech birth at around 1 out of 500 compared to 1 out of 1,000 for planned cephalic birth and 1 out of 2,000 for a planned cesarean section. This number aligns with many large national registries and meta-analyses. However, in France and Belgium, which have retained a strong tradition of vaginal breech birth and continue to teach breech in residency programs, large, high-quality prospective studies have found no differences in neonatal outcomes. And there's a lot of comparison of many studies in this article, too, so I encourage you to read the whole thing. So it used to be taught routinely. It's something that is taught routinely elsewhere. Now it's no longer really taught. There was a study that came out, I think it was 2003. It's called the Breech Trial. And it pretty much put a death knell in the idea of any planned vaginal breech births. And since then, most hospitals will not even permit a woman to attempt a vaginal delivery with a breech baby. Mostly, I think, because nobody's trained in that delivery. And also, hospitals tend to operate on a risk reduction paradigm. So it used to be taught routinely. We have fewer birth workers who do this, but there seems to be a higher percentage of birth workers who are certified in, repositioning or delivering breech babies among midwives. So in New Hampshire, the hospitals won't attempt this. The policy is C-section is the only option. So what's a mom to do? She's 37 weeks. She's been seeing a midwife the whole time. Her baby's still breech. And now she's really concerned that she's going to have to just go to the hospital and have a C-section. ACOG and JOGC both give the green light for vaginal breech births to be attempted in hospitals, but their recommendations are silent on vaginal breech birth in the home setting. Advances in Labor and Risk Management International have selection criteria for planned vaginal breech deliveries. Their key messages are the decision to perform involves providing informed choice to the woman regarding risks, benefits, and healthcare provider competencies. When a woman presents with a breech baby, a vaginal delivery should be encouraged if she meets the criteria, and health providers should develop and maintain their skills in vaginal breech delivery. The WHO guide that you have in front of you also has a guide for breech birth, which I passed out. Multiples, that's more of the same. Yes, there is an increased risk of complication, but healthy multiple deliveries do occur in homes across the United States all the time. In other states, midwives deliver twins, and it's not precluded in their scope of practice. So this is really just about, expanding what moms can access, because right now it's either go have a C-section or give birth alone in your living room. So I appreciate any discussion on this, and thank you for the time.
Thank you. Any questions? Representative Seth King.
Thank you, Mr. Chair. Thank you for taking questions. I'm sorry if you already mentioned this. I missed it. It says here, or the patient having had fewer than 3 previous cesarean sections. Again, sorry if you already talked about that, but can you just elaborate that? That seems kind of weird that there would be a rule that would say if you've had 4 or more cesarean sections, then it's okay for you to be a midwife. But if you've had less than that, it's not allowed. I don't know. I just don't get it. Thank you.
Thank you for the question. So it's to allow up to 2 previous cesarean sections. Right now, you can only have midwifery care if you've had 1 and no more than 1. No rule shall be adopted requiring denial of care for the patient having had fewer than 3 previous cesarean sections. If it's not clear, we can make it clear. No problem.
All set? Okay. Representative McLean.
Thank you, Mr. Chair, and thank you for taking my question. Do you have any data on the occurrence of home births where the services of a midwife have been denied?
I don't have statistics on, how often that occurs, but there's many different reasons why um, a midwife would decide to transfer care, and not all of which is even covered in the administrative rules that are governing them now. But it happens fairly often, usually not during the birth. Usually some risk factor is identified prior to even the end of gestation when the due date is arrived at. And so they'll have to transfer care. Even being, so in the rules, there's a lot about you have to consult with a MD or specifically an obstetrician or a CNM, certified nurse midwife, regarding continuance of care for certain things that pop up. Which again, I think I'm not a fan of those. I feel that the midwife should make that decision. This is what they do. This is where their training comes from, and they are not going to put a mom in jeopardy. This isn't new ground that we're breaking. This is an ancient traditional position, but I digress.
Thank you.
Representative Merchant.
Thank you, Mr. Chair, and also thank you, Representative Cushman, for taking the question. I always thought of pregnancy being somewhat of a high risk, and you sort of alluded to that, I think, in the testimony, where if you have one vaginal delivery, one C-section delivery, and then you follow it with a vaginal, it's 0.7% with complications. But if you get to 2, it goes to 7%, which is concerning. Do we have any stats from the Office of Professional Licensure and Certification in regards to concerns and complaints filed against midwives, and try to understand from the public what has been voiced with concerns to the Office of Professional Licensure and Certification for investigations or to complaints?
Thank you for the question. I think that we could leave that for them to answer. I don't know about the complaint rates. You had mentioned to me that you had heard that they were higher among midwives. I don't know why that is.
Thank you.
Other questions? Representative Shapiro.
Thank you, Mr. Chairman. You referred to the education that needed in order to be certified as a certified midwife, which is distinct from a certified nurse midwife.
Correct.
Could you refer us to something that would elaborate on what that education is, how long, and what kind of
Sure.
programs?
Yep. Let me pull it up. So the American College of Nurse Midwives certifies nurse midwives and certified midwives. The NARM, National, sorry, I forget what the National North American Registry of Midwives also certifies. So you can, I can send you, what they do, but it's a full program. And then you do a preceptorship with a current midwife where you attend a certain number of deliveries and prenatal appointments, and you get a certain amount of experience that is signed off on. It's very extensive. It's in mid 300, I believe, section of the rules, if you want to look at them closely. But it's not easy. It's a very challenging process. And I've never worked in midwifery, but I've considered pursuing it and going that route. But it is very cumbersome of an education to consider pursuing.
Follow up? Yes, I think that you referred to the complication rate with vaginal birth after a C-section, but I don't know if you did the same with breech births. But do you know of any information that might compare the complication rates or the outcomes with vaginal breech births done at home versus done in a hospital?
In the article that I sent you titled "The Bottom Line on Breech," there is a table
that talks about the role of malpresentation in high risk births and neonatal outcomes, and the author does expound on the setting also. So like some of these have different settings, and you can see in the findings what the settings were. So there is some data on it, although it's very limited. Most studies didn't differentiate that. Some studies don't differentiate whether they're planned vaginal breech births or unplanned, or if the provider was trained in that or not. And it's also important to mention there are organizations that specialize in training these birth workers for delivering vaginal breech births. And of course, they're going to have a higher success rate. And there's also organizations such as Breech Without Borders who will offer telehealth services during a birth to assist with that. And there's also, if we're talking about the risks and trade-offs, on page, it says 15, but it's the back of the second page in that packet. There's kind of a comparison between the risks of cesarean section and the risks of a planned breech vaginal birth. And so there are some, like for every, it would take, I believe it was 8,500 elective C-sections for breech babies. There were 8,500 elective C-sections for breech babies from 2001 to 2005. That 8,500 potentially saved 19 babies. That's wonderful. And then there's also the cost of 4 avoidable maternal deaths for C-section on the other side, 9 fetal deaths in the future due to a uterine scar. So if there's a scar and the placenta attaches to the scar, it can cause an abruption later, and then the baby loses their blood supply. 140 life-threatening maternal complications in future pregnancies as well. So there's a big picture that needs to be considered, not just the breech delivery itself, but other risk factors, and then the risk of cesarean section alone.
Other questions? Seeing none, thank you. Also signed up to speak is Representative Paige Boschman from Nashua. You've asked for 3 minutes.
Thank you, Mr. Chair, and thank you for having me here, committee. Some of you met me last week. My name is Paige Boschman. I am a registered nurse. I have been a nurse nearly 15 years, and most of that time I have been working under the midwifery model of care. I am not a midwife, thought I wanted to be, not my deal. I don't want to resuscitate babies, but I'm an educator, and a lot of that education has been on educating the public about the difference between certified nurse midwives, professional midwives, midwifery care, and the merits of it, which are very high. I would like to thank Representative Cushman for bringing this up. I think that it's a big issue that we need to be talking about more. And I think that the intent of it is, frankly, it's a refreshing relief. At the same time, I have just a few concerns about it. And I just wanted to really clarify the difference between a certified nurse midwife, which a certified nurse midwife has a bachelor's degree in nursing and then goes on to get a master's or higher level degree as an advanced practice registered nurse. They are very similar to, say, a women's nurse practitioner. That is the level of training that they have. Certified professional midwives, also highly trained, just in a different model. And I'm not as familiar with the extent, but you've got the resources for that. It's important to understand the difference, but that we use the word midwife for both, even though they have different trainings and practice. To be very clear, this bill is specific to the certified professional midwives. They have their own council by which they are regulated, which is different from CNMs, which are regulated and licensed through the Department of Health and Human Services. I would like to say that midwifery care is amazing. I've had all of my babies with midwives. I've been that person that had one cesarean, one VBAC, and then wanted another VBAC and had to transfer from a CPM to the hospital and have a C-section. So I really understand this situation. The biggest concern that I have after speaking with CNMs and CPMs in this state is that this request didn't come from the council, and there is some significant concern on their end. Reason being, midwifery has not been taken seriously for many, many decades, and it's taken the last few decades for them to gain the reputation that they deserve. Midwives provide very, very safe maternity care and births for low risk pregnancies. And in fact, one of their greatest skills is recognizing when a higher risk comes up and then transferring them their care to OB-GYNs, it's the way that we should be working together. In terms of this, some of the midwives are concerned that the bill as written could lead to worse outcomes, which could tarnish their hard worked for reputation, which they've established in the state. So as a recommendation, again, I would recommend that we discuss this, but we turn it back to the council and the midwives in the state and ask them what would they like to be able to do? What makes sense to them? What are they comfortable doing? In addition to
Your 3
that,
minutes are up. If you could please start wrapping up.
I will absolutely add one more point, and the one point was in terms of the distance from the hospital, another thing we should talk about is that due to reimbursement, we're seeing across the country, but also in New Hampshire, maternity wards closing down in hospital after hospital. And if we do continue with this distance from hospital rules, it makes it less and less accessible. There's lots of problems with closing maternity units anyway, but it makes this even harder to adhere to.
Okay,
Thank you.
Any questions? Representative Nadarapam.
Thank you, Mr. Chair. So overall, are you against this bill as it is currently written?
I'm sorry, yes, I'm opposed to the bill as written.
Okay, thank you.
Representative Merchant.
Thank you, Mr. Chair, and thank you for taking the question. In regards to a hospital, is it required that the hospital have maternity care or just that you have to be close to a hospital?
So I won't say, what I'm understanding from this is that for most midwives who will deliver in a freestanding birth center or attend home births, right now there's usually a recommendation for how far that space can be, say a person's home, from the nearest maternity unit, so that if a birth becomes high risk and they need to transfer, they're close enough to get that care in time.
Representative Seth King.
Thank you, Mr. Chair. And thank you for taking questions. I always love your testimony because you come from such experience when you have such experience in,
Thank
in
you.
what you're talking about.
I did forget to mention I'm representative, so thank you for those that didn't know.
You mentioned that this isn't coming from the council. And what I don't understand is, so the council is made up of people who, I think the reason why this bill is being introduced is because the council has historically been overly conservative in their rulemaking, and this is sort of taking the risk away from the council, because the council doesn't want to make a rule that could backfire and then they get blamed, and we're taking the responsibility for overriding their rules. So my question is the council only made up of people that are like really staunchly pro midwife, or can it also be filled with people that generally have a negative view of midwifery? Thank you.
Thank you for your question. I know that there are folks who represent that council, and so I'll let them speak to that fully. My understanding is it's made up of CPMs to regulate, and I'll let them answer it.
Other questions? Seeing none. Okay, thank you.
Thank you very much for your time.
Also signed up to speak, and I hope I can pronounce this correctly, Kathy Chung Hua from Dartmouth Hitchcock. Am I close? Okay, good. You asked for 5 minutes. Could you keep it closer to 3 minutes, please? There you go.
Can you guys hear me now?
Oh, yes.
Okay, so my name is Kathy Chung-Hwa Yi, and I have been in practicing OBGYN for 27 years. And I submitted a written article opposing this House bill. And I cited a Washington Post article, investigative journal, that came out in a state of Maryland where a couple has filed a complaint against her midwife for poor outcome. And I want to state that in that article, they cite that home birth has twice the amount of infant mortality than hospital birth. The second position is that twin deliveries or multiple gestation pregnancies are very high risk. And most of these babies are born preterm, and therefore, when they're born preterm, they already need hospitalization and hospital care. In my experience, twin pregnancies are one of the more complicated conditions, not only for the baby, but also for the mom. And in my personal experience, when I'm faced with delivering twins, it is something that I take very seriously. So in my background, I have done tons of deliveries, both in the setting of working in the hospital here in Concord, and I'm now working at the Catholic Medical Center with certified nurse midwives. We have a very collaborative relationship with the midwives, and I do support midwifery care. The distinction is that in this bill, you are allowing deregulation of some of the restrictions that have been put in place to safeguard the patient. So this bill allows patients or consumers to decide what is the best option for them. In my opinion, I think the government and the regulatory board and the licensure committees exist to protect the public and allow the lay public to make good decisions. By allowing the public to decide now where to choose care, I think it endangers the consumer, because lay midwives working in a hospital setting, certified nurse midwiferys with doctors is a very safe environment. But if it is a freestanding home delivery situation, the multiple birth pregnancies, unstable presentation such as breech, and mothers laboring with prior uterine scars is a very high-risk situation. And the American College of OBGYN stands to support deliveries of prior cesarean deliveries in a hospital setting. And the twin deliveries also should be supported by high-risk OB doctors. So my position is that this bill poses the choice of seeking care to the lay public. And I think the government and its agencies should exist to protect the public for making good choices and good options. And by deregulating or allowing the patients to have more choice in this particular situation, it is reckless endangerment, I guess, of the public.
Okay, thank you. Questions, Representative Weber?
Thank you, Mr. Chair, and thank you for taking my question. Your testimony brings up something that I hadn't even thought about before. When a patient has a relationship with a certified midwife and a complication arises and the certified midwife is either required to or decides that the patient needs to be transported to a hospital, does the relationship with that midwife end at that point, or does the midwife continue to support the patient but supported by the more specialized levels of care? I mean, it sounded to me when I was listening earlier that if the midwife isn't, if the rules prohibit the midwife from doing the delivery, that care ends. And
I think it's very individual. Some midwives will come with the patients to the hospital, but I think that is pretty individual. So in my personal experience, some of the more difficult outcomes or poor outcomes were associated with freestanding midwives doing deliveries at home that did not end well. And as doctors, we're taking all comers and taking care of patients equally. But when you're faced with a situation that, in my opinion, could have been prevented or proactive care administered, it is kind of hard. So there have been there have been 2 cases of infant death when I was at Concord Hospital, associated with the midwife delivery I guess, not as anticipated at home.
Representative Murphy.
Thank you, Mr. Chairman, and thank you for taking my question. We've heard a lot about the training of midwives, the nurse practitioners that care for these patients, for physicians, OBGYN like yourself, that take care of these patients. If you took this bill and you substituted the word experienced, highly trained OBGYN with many years of experience for midwifery or the midwife, would it still meet the standard of care, taking care of patients, pregnant women and their babies?
So what you're saying is doing an OBGYN trained doctor like me doing a freestanding home birth?
Right, with any of these potential, scenarios?
I would not sign up for that.
Thank you.
Representative Shapiro.
Thank you, Mr. Chairman. So when my oldest daughter was born, we were going to a freestanding birthing center with nurse midwives, and my daughter was breech and continued to be breech, and so she risked out of that program and was delivered in a hospital by the associated doctor. And it went fine. So it was a vaginal birth and it went fine. So what would my wife and my daughter have risked by being in a setting other than a hospital? And what were the risks even in a hospital? And how would having been in a hospital mitigated those risks? Had something, I mean, I understand from earlier testimony that those kinds of births are not done currently in New Hampshire. But if they were done, what is the risk that we're talking about? What could go wrong?
Okay, so to answer that question, in a hospital setting, you have a operating room ready for anything emergent. In a breech birth, if the baby is entrapped in the mother's womb, after the body delivers, the head is entrapped. That is a very difficult situation. And so I think you just have more resources so that if there are any unforeseen emergencies that can be taken care of quickly. If you're in a freestanding situation and you're kind of far from the hospital, even if it's like within 10 or 15 minutes, if the baby's not delivered in a timely manner, it could affect the outcome. And I differ with the midwife's position that hospitals do not allow breech birth. It is a shared decision-making process, and we do offer external cephalic versions. So mothers have a choice with their doctor to decide if they want to try to turn the baby. Breech deliveries are kind of tricky. So as an OBGYN, in my 27 years of experience, I don't do a lot of breech birth because we're not doing a lot to begin with. But I did have a breech birth vaginally at CMC with my midwife at 3 a.m, and everything went fine. So it depends on the situation. So it depends on your comfort level and how the patient's doing. But the amount of resources that you have allows you to feel the comfort to take something on that's potentially risky.
Thank you.
Representative Weber.
So I think that you've answered my question with that last answer, but I was going to ask, is it true that there are no breech births done vaginally in hospitals? And what I'm hearing you say is, no, that does happen, but it's very much an individual. Am I right in thinking it's very much an individual consultation and decision?
Yes, it is really a shared decision between you as a provider and the patient. So if you're somebody who has some anxiety or you don't have a lot of comfort because of your training, it is your obligation to let the patient know what your comfort zone is, and you can call a backup doctor, and sometimes that happens. If the patient is really motivated and you want the best option for the patient, which you determine is a vaginal attempt, you would try to see what you can do to allow the vaginal birth to happen. So it happens invariably, but again, breech deliveries are not something that we are trained to do currently in this model, but it's not discouraged and it's not something that is prohibited.
Representative Seth King.
Thank you, Mr. Chair. Thank you for taking questions. I think we've established that midwives are highly trained, well-educated individuals. Would you agree with that?
Yes.
Okay. Follow up.
Follow up.
That being said, if under most circumstances a midwife is presented with one of these scenarios, do you think that they're automatically going to just take on the task and do this like at a home birth? Or do you think that they're most likely going to defer to the hospital anyways? And the reason I ask that is because it sounds like, based on the testimony of the co-sponsor or the sponsor, that you're not likely to see a lot of midwives performing births under these scenarios. It's more for the patient who refuses to go to a hospital, and this at least allows somebody to be there who is trained to help with the birth, as opposed to them having birth all alone. So can you just, what are your thoughts on that? Thank you.
I really don't know what was the impetus for the House bill to be presented. So maybe that's it, that for these patients who truly choose not to be in a hospital setting, it allows them some midwifery or some obstetrical support care. Yeah, I honestly don't know if I can answer that fairly because I'm a little bit biased from my own experience.
Other questions?
Thank you.
Seeing no other questions, thank you. Also signed up to speak is Beth Gaby from the New Hampshire Midwifery Council. You've asked for 2 to 3 minutes, that's fine. Yes,
Now?
maybe, yeah, that's good. Yeah.
Okay. My name is Beth Gaby. I'm a New Hampshire certified midwife. I do home birth in the state of New Hampshire for the last 16 years. Before then, I was in Pennsylvania, which is not a regulated state, and we did, this is just a little story, we did home, breech, and twin deliveries. In New Hampshire, we don't. We're regulated, and on behalf of the Midwifery Council, we oppose this bill as written. That said, I invite anybody who wants to have more discussion about the bill to come to the next Midwifery Council meeting, which is on February 22nd, on Thursday at 1 o'clock over at Eagle Square. So as a council, we oppose this bill. We had not heard about this. Nobody approached the council to discuss this. We have being a regulated state, we have rules and very clear guidelines when you consult, when you transfer what is considered a low-risk birth. And in those guidelines, we consider breech birth and twin births a higher risk birth. That said, there's room for more discussion about this bill because the OBs do not do breech births in the hospital. They are incredibly rare. And when we call ahead, if we have a breech delivery and we need to come to the hospital, we'll have nurses say, well, better not come here, go to some other hospital. Nobody here is going to do this. We're trying to find somebody willing to do a breech delivery. And to my opinion or my experience, the OBs are not, there are a couple who are interested in helping us out, helping out the woman if they're, there are guidelines as what's a higher risk breech versus what's a lower risk breech. And so there is a lot of education in the midwifery sphere that I think is very useful to OBs and midwives in general. So I guess I'll repeat the last thing is that we oppose this bill, the Midwifery Council. However, I am interested in more discussion about opening up choices for mothers who are a decent candidate, who have a frank breech, to have a safe vaginal breech delivery.
Okay, thank you. Any questions? Representative Seth King.
Thank you, Mr. Chair. Thank you for taking questions. I gleaned from previous testimony that the Midwife Council is full of individuals who are midwives themselves and are pro-midwifery. Is that correct?
Yeah, I'll just tell you who's on the council. We have one obstetrician, one pediatrician, 3 midwives, and 1 public member.
Okay, thank you. Follow up?
Follow up.
It was also alluded to by a previous individual that by liberalizing the rules for midwifery, that there would be a fear that something bad would happen and it would look bad on midwifery in general. So by opposing this bill, I'm curious if the reason the Midwife Council is against it has more to do with the safety of the birthing process, or if because you're worried that something bad will happen and then the legislator will down the line say, that's it, we're banning midwifery altogether. Can you explain? Thank you.
Yeah, I guess I take a different approach than when you said liberalizing. Liberalizing the rules. To me, it's more like we could not move forward with this because there needs to be training. You can't just say, I'm a midwife, I deliver breech. There are great trainings for midwifery in the midwifery sphere, which is to my mind, very different than what the OBs are learning, is very different from what the midwives are learning. I'd love there to be some cross-talking there. But midwives in New Hampshire, they would have to show that they have had specialized training in breech. That's not a given. And so there are places to get that. You can go to Tennessee, you can go to the border, you can go to Haiti, you can go all over the place and get training from midwives. But we don't have that right now. We also, the insurance, we can have insurance coverage because we're regulated if we choose to. We would like to know, would insurance companies cover us if we did breech deliveries? Would a midwife have to agree not to do breech delivery if she wanted to take insurance? These are unanswered questions. Also, it's just as the rules are currently, it's not in the rules, and I think you need to go through a stepwise progression to introduce it and cover the safety. It is a public safety issue. The council is in place to keep the public safe. And so we wouldn't willy-nilly say, okay, now midwives can do twins and breeches at home, because we haven't stepped up to those safety measures. So rather than liberalizing, which feels like you're kind of taking away barriers, it's more like stepping it up to make sure that you have safety measures in place.
Representative Murphy, and then
Thank you, Mr. Chair.
Representative McLean.
Thank you, and thank you for taking the question. So it was a follow-up to Representative King's question in a sense. I was curious as to why the council actually opposed the bill, but are you saying that if the midwives were specifically trained in breech deliveries, that as written then, with that amendment, you would be supportive of this, meaning that you would have home deliveries for breech babies, prior C-sections, et cetera?
So I would take separately twins as a separate question, the breech is a separate question, and the cesarean separate question, as well as the minutes away from the hospital, which is also in here. I think it's worth more discussion simply because if anybody's ever heard of free birthers, free birth, it's people who do not use a midwife and do not use an OB, and they do their own birth unassisted at home. And there is truth. There are not very many, but there is enough to talk about women who will enter a more risky situation because they cannot have their vaginal breech delivery from any practitioner that's available, midwives, OBs. I got off track. I don't remember the question. I'm sorry.
Just to follow up.
Follow up.
So again, to be clear, I guess we.
Open to conversation. I guess the point is as this bill stands now, we're opposed. But I invite people to come to the council meeting and discuss it, because there are women who don't have options, and I think that's worth discussing.
Sure. So given the prior testimonies by midwives and physicians about the increased risks with this subcategory of patients with home delivery, even if the midwives were trained in breech deliveries, would that change your opinion or the council's opinion about home delivery in a breech situation?
I would have to ask the council. My personal opinion, if there was specific training and numbers of breaches that you had to show that you did, and you could open up the possibility of having specialized midwives specialized in breach who could do breach or maybe even do it with the OB in the hospital, then yes, I am in favor of having that conversation.
In the hospital.
Well, even, I mean, I did breaches at home in Pennsylvania very successfully. So I think there's a lot of fear around it. And I wasn't trained with fear around breaches. But we also had to triage. There were certain breaches we did not do at home because they were higher risk breaches. There are lower risk breaches as well.
Representative McLean and then Representative Merchant.
Thank you, Mr. Chair. Thank you for taking my question. So, leaving the issue of the breaching aside, you're talking about limited options for women. I mean, I'm not a doctor, but I hear on the radio a lot, we're closing down this maternity ward, we're closing down that maternity ward. So, looking specifically at the distance provision, because people's access, especially in the rural areas of the state, is diminishing. What are your thoughts with respect to the distance provision in the bill, maybe as it would relate to non-high risk births? Would you be comfortable with that provision in the case of non-high risk births, or do you still have reservations around that?
So currently the regulations state that if you are having a home birth, there is no this is not a VBAC, vaginal delivery after cesarean, vaginal birth after cesarean. That's a VBAC. There is a provision that you need to be within 20 minutes of the hospital. If you don't have a VBAC and you're just having a vaginal delivery, there is not a time constraint on numbers of minutes away from a hospital. So it doesn't, like in the North Country, when you're going to be far, there isn't. However, with a VBAC, there's the 20-minute provision in the current rules.
Follow up.
And do you think that's a valid? So I'm just looking at, because people in rural areas with respect to access.
So, this is my personal opinion because I haven't discussed this with the council. My personal opinion is if you are going to have a VBAC and if you're going to have a catastrophic uterine rupture, then 20 minutes is too long to be away from a hospital. So when we have, the risk is low. It's low enough that midwives in the state, we do VBACs and we have women, full disclosure, they have to understand what the risk is. But in my opinion, it's fine if you are willing, if you know you're a VBAC and you're 45 minutes away, then that is totally fine because the risk is so small. If you go into that small percent, if you are not in the hospital, you are at risk. Like 20 minutes doesn't make the difference. You want to be in the hospital fast. So that's my personal opinion. I would not have a problem with saying if somebody wants a VBAC, the risk is so low, I don't expect a catastrophic problem. And they have the choice to understand that there is this percent of a catastrophic problem, and I'm willing to take that.
One more follow-up.
So just to clarify, so if you were to amend the bill just to keep that section in, you would still not be comfortable even with that section?
I don't really worry about that section.
Okay.
Yeah.
Thank you.
Representative Merchant.
Thank you, Mr. Chairman, and also thank you for taking the question. Earlier, I asked a question to Representative Cushman about the complaints and investigations with midwives in the state of New Hampshire, and I think it comes under the OPLC. I was on a committee during the summer of 2022. That issue was raised about the number of concerns that were raised by constituents, by people who were concerned about their midwife as far as their delivery. And what I'm trying to get to is, can you share with us, being on the advisory council of midwifery, the number of complaints and concerns and so forth that come to the council that have been investigated and what the outcomes were, some idea of what's out there publicly?
Just to clarify the question, are you asking like how frequent are the number of complaints about poor practice in midwifery out there?
I wasn't quite sure exactly what the comment was at the time, but I believe there's about 34, 35 midwives in the state of New Hampshire.
Yeah.
And there seemed to be a disproportional number of complaints against that subset of 34 people compared to some of the other professions.
Well, I guess there's probably somebody who can answer this better than I. Sitting on the council, we receive those complaints. We have very few complaints. Very, very few complaints.
Is there a way to quantify that with the numbers? Somebody would not be able to say.
I will have to ask for the specific numbers, like in a 5-year period, how many complaints we get.
Correct. If I can. What I'm trying to get to is what is the risk currently that people perceive, rightly or wrongly, that's been voiced with the council to get a measurement of, if we try to look at that going forward and we build on it, are we looking at concerns and complaints with the midwiferys, if you will, within the state, where it is today, because this will change things based upon some risk factors, what that may mean to the constituents going forward.
Okay.
The baseline.
I think the best, if somebody's able to voice that question a little differently, I might be able to understand it a little better. Okay, could you mind if it's just reworded
Representative Weber.
for me? So I'm sorry.
I think it would be very helpful, at least for me, not speaking for Representative Merchant, if we knew the number of complaints that you had in the last 5 years and whatever is publicly available as to the content of those complaints and their resolutions. That would be very helpful.
Okay, I'm happy
that
to
what
get
you wanted?
that.
Thank you.
Just another point is that we get both, if things that come to the council are both complaints from the outside, whoever that may be, as well as if a midwife herself has a significant morbidity or mortality, she reports that. And so we look at all of those reports coming in. The number of M&M reports versus complaints, it's very, I mean, we get, I would say in the last 5 years, I mean, we've probably gotten less than 5 complaints. But I can get those exact numbers for you.
Okay, thank you.
From the
Other
council.
questions? Seeing no other questions, thank you.
Thank you.
Also signed up to speak is Dr. Young from I believe it's the New Hampshire Medical Society. Good afternoon, Doctor. You've asked for 5 minutes. Please try to keep it around 3.
Thank you for allowing me to testify today. I really appreciate the fact that we have this opportunity in the state of New Hampshire. My name is Dr. Og Young. I'm here strongly opposed to House Bill 1010. I'm a retired OBGYN who practiced in Concord for 40 years and taught Dartmouth medical students during that entire time. I'm also past president of the New Hampshire Medical Society, and I continue to serve on the general council of the New Hampshire Medical Society, representing all the obstetricians in New Hampshire. The most dangerous practitioners in medicine are those who do not know what they do not know. This bill represents, to me, an egregious example of this well-known medical saying. Allowing certified lay midwives to care for high-risk pregnancies out of the hospital with very little training. It's important to understand that a lay midwife is certified with simply a high school diploma and observation of 25 vaginal births by another lay midwife. As you've heard, this is very different than a certified nurse midwife who has a bachelor's degree in nursing and 3 years of training in a hospital under the supervision of other certified nurse midwives and obstetricians. These nurse midwives, interestingly, choose to practice in hospitals under the supervision of obstetricians because they know what they do not know. I had a year of internship after medical school and 4 years of OBGYN training. I cannot imagine a certified lay midwife wanting to take on the responsibility of caring for a pregnant woman in labor who has a baby in a breech presentation, who has multiple pregnancies, who's had previous cesarean sections. These are situations that were the most harrowing situations for me as a physician. Now, I understand today the standard of care in most places is a cesarean section for a breech presentation. I trained and was trained to do breech vaginal deliveries. But all of us who had that experience also experienced occasionally a horrific complication with that delivery. And I wanted to show you. This is from props that I use.
Sir,
Props that I use.
you can't use props in here, I'm
Oh,
sorry.
really? Sorry. Okay. Well, it's the after coming head that gets stuck. And it's very difficult to deliver. And I know of babies, newborns that have suffered death because of that. I can't imagine delivering a breech baby out of a hospital situation.
And your time is running out. Please sum up, please. Wrap up.
A second twin can come down with an arm or a shoulder or a leg and be impossible to deliver vaginally. Twin pregnancies should be delivered in the hospital. And finally, some of us performed emergency surgery after a ruptured uterus, finding the baby floating in the abdomen. I cannot imagine being in a home or outside of the hospital when that happens to my patient and baby. So just one final short story. I attend South Church most Sundays in Concord. And I sit near a young girl who's 13 years old now, name's Angela, who suffered prolonged birth asphyxia when she was delivered by a certified lay midwife. She came down with a tight nuchal cord, umbilical cord around her neck, and the midwife did not resuscitate her. She ended up in Concord Hospital ER 45 minutes later. Now she doesn't walk, she doesn't talk. She's a beautiful, bright girl, but is confined to a wheelchair.
All right, sir. Thank you.
I know the parents well. I know the parents well, and they have long forgiven the certified nurse midwife or certified midwife who delivered her, but they cannot forgive themselves.
Are there any questions for this
Please
gentleman?
vote ITL on this bill so that we're less likely to have babies
Are you taking
like
questions? Are
Angela.
there any questions?
Thank you.
Seeing none? Thank you. All set. Also signed up to speak is Representative Emily Phillips. And you asked for 3 minutes.
Good afternoon. I am a co-sponsor on this bill, Representative Emily Phillips, Fremont, New Hampshire, Rockingham 7. This bill was brought forward because people asked us to. Birth is not a medical event or an emergency most of the time. For a millennia, midwives or lay people, if you will, have been helping to birth children. I myself was excluded from birthing vaginally twice, but the second time I ended up with a C-section based on a mirage of a myriad, sorry, of interventions that were pushed upon me in the hospital setting. So I ended up with 2 C-sections, and then I couldn't find a provider to allow me to try to deliver my child the way I wanted. The only option offered to women in New Hampshire, let me be very clear, is surgical. Okay, for many of these conditions. So I was seeking a vaginal birth after a second cesarean, and nobody in this state, this was 2.5 years ago, would allow me to deliver vaginally. I played the good game and I went to the OBGYN. I saw a midwife as co-care, and I was just hoping that somebody was going to support my choice. At 37 weeks, I asked for it to be considered individually based on my personal health and my pregnancy, and not based on a label. And I was laughed at, and I said, they told me I was literally the worst candidate they had for a vaginal delivery there, and so I went home. I gave birth in my bathtub alone with 2 doulas. Doulas are not medically trained. They are birth support workers, and I'm thankful they were there. My baby had a double nuchal cord. He was fine. Also, that's a variation of normal. I had 2 prior C-sections. I did my research, and statistically, a woman who's had 2 prior C-sections are very serious surgical surgeries, and I appreciate obstetricians who do them, and they are necessary sometimes, okay? There is no way that you can say that major abdominal surgery is a no risk, no big deal. It's major surgery. And if I want to go on to have a 4th child, what is the risk to me for having 3 major C-sections? Where does my risk tip to the point where a uterine rupture also occurs at the same level when you get to your 4th C-section? Okay, I want to live, I want to raise the kids I have, but I did not want to consent to surgery, and nobody would allow me to try. If I had shown up at a hospital, and I'm sure an obstetrician here can back me up, if I had shown up and declined this surgery I was told I had to have, they would fight me the whole way. While I was trying to labor, they would fight me. And I've heard stories of women being denied pain medicine. I've heard stories of women being treated poorly and triaged and end up delivering in an ER because they're mad that the woman will not consent to their hospital policy or rule or whatever, that they must consent to surgery. Women are free birthing in New Hampshire. It's happening around me. I'm friends with them. That is within their risk to take. I understand their statistics, but it is my risk to take. Nobody faces more long-term liability than the mother herself. What happens in that birth would have been my fault. Okay, my son is healthy and fine and everything went well. Statistically, I knew that would be the case. Instead of getting all the interventions at the hospital, I knew that he would be healthy, and thankfully that's what happened. But if something had happened, that would have been on me.
Please wrap up.
Yes. If the committee is willing, and maybe if the midwife council or other people would help, could we amend this bill to take what I believe to be the lowest risk, which is a vaginal birth after 2 cesareans, and amend it down to that maybe? But there are women who will choose to give birth alone, who won't have as good as outcome as I had, perhaps, if we don't allow more access to midwifery care across the state. Thank you.
Thank you. Any questions? Seeing none. Thank you.
Thank you.
Also signed up to speak, and hopefully I pronounce this correctly, Dr. Shudhari, representing themselves. Was I close?
Pretty close.
You asked for 3 minutes, sir.
Thank you for allowing me to speak. My name is Ashish Chaudhary, and I'm a board-certified OBGYN with over 2 decades of experience delivering low-risk and high-risk babies in the state of New Hampshire. I'm the service line leader for Dartmouth Health OBGYN services in the southern half of New Hampshire, overseeing the services of 15 OBGYN physicians and 13 clinical nurse midwives who work at different hospitals, 3 different hospital birthing units in the state. Additionally, and germane to this discussion, I have a master's degree in health care delivery science, which is the study of how healthcare is delivered, factoring in location, available resources, population demographics, healthcare disparities, costs, and most critically, patient safety. My fellow opponents to this bill have spoken and will speak further on clinical data and their experiences in providing care. They provided their reasons for wanting to restrict the delivery of a pregnant mother with high-risk concerns of malpresentation or breech, multifetal or twin gestations, and a trial of labor after 3 cesarean sections. to be undertaken should be undertaken at a hospital setting. I wholeheartedly agree with these statements. I would like to offer another view of this matter. There's already a rift in some areas between the community midwives and physicians. Some community midwives and their patients have a distrust in the formal medical system, feeling that many interventions are unwarranted or unnecessary. Some hospital-based providers have been on the receiving end of out-of-hospital births gone wrong, only to find that the time to safely intervene had passed, sometimes resulting in a damaged baby or worse, and other times mothers and fathers with emotional scars that will last a lifetime. Passing this bill would allow community-based midwives to care for patients with extremely high risks to mother and baby outside of the safety net of a hospital. This will lead to more intrapartum emergencies and transfers to facilities where there might already be a bias against the out-of-hospital birth population. This would further tarnish the relationship between the community midwives and the OB units when they present only when things have gone wrong. It would undermine the trust that has developed in many communities amongst the community midwives and their local OB providers and hospitals. Why should we knowingly allow some of the most high-risk issues in obstetrics to be cared for without a safety net? As a practicing OBGYN, each of these conditions warrants a hospital care and continuous monitoring of the baby and mother to ensure a safe birth process, which is what we all want. To do anything different would be negligent on the part of those who facilitated it. Perhaps an analogy might make it clear. We can agree that a baby is perhaps anyone's most precious belonging or commodity. Parents would step in front of bullets or bears or buses to prevent from any harm occurring to their baby or child. Just as most car rides are uneventful and end with a safe arrival, I believe that the majority of low-risk births can be similarly accomplished safely with good labor support and without extra or undue medical attention. Yet, we still put our babies in car seats to get them from point A to point B. Not because we're expecting a car accident, but so our child can be safe in the event of one. Then add a snowstorm like the one we had last week. You better believe that most parents would not go out in that storm, but if it were absolutely necessary, they would make sure their baby was strapped tightly and securely in that car seat, just in case.
Please start wrapping up.
Allowing out of the hospital birth attempts of breech babies, twin pregnancies, and vaginal deliveries after multiple C-sections without the safety net of the hospital and all it can provide is in an emergency is like driving your baby out in a snowstorm without a car seat. It would be negligent to do so. House Bill 1010 goes against all that we do to keep mothers and babies safe during the labor process in our state. I'm adamantly opposed to this. Thank you.
Any questions? Seeing no questions, thank you. Also signed up to speak is Dr. Amy Lee, representing herself. You've asked for 3 minutes.
Hi, my name is Amy Lee. I'm a New Hampshire resident and also a resident OBGYN physician. I'm additionally speaking on behalf of the New Hampshire Medical Society as well. I'm here today to oppose HB 1010. I want to disclose that this testimony contains content that may be triggering to survivors of birth trauma. New Hampshire is a relatively rural state with expanding maternity care deserts. A major factor influencing the safety of a planned home birth is the availability of safe and timely transfer during labor or postpartum. The reported risk of needing transport to a hospital during labor is up to 37% for first-time moms and 10% for women who've had babies before. In areas like New Hampshire, without a health system built for home births and where the receiving hospital may be remote, there is the potential for delayed or prolonged transport during labor or postpartum. This will ultimately result in higher rates of death for mothers and infants. Now let's add the high-risk scenarios of long-distance travel while in labor or postpartum to HB 1010 scenarios. I'll illustrate some scenarios that can and will happen if HB 1010 goes into effect. Imagine a baby is being born breech, meaning feet or butt first. The head is the biggest part that must pass through the maternal bony pelvis, which means the space between the hips. Let's say the body comes out, but the head gets caught. What happens is that the umbilical cord gets compressed between the infant's head and the maternal bony pelvis, cutting off the infant's oxygen supply. The infant asphyxiates. The mother then needs to be transported potentially hours with her dead infant half delivered. If the patient were in the hospital or very close, forceps or a cesarean could have urgently been performed to potentially save this baby. Twins carry a higher risk for breech presentation and are therefore at risk for what I just described. What is also concerning about twins is that they have an 18-fold higher risk of postpartum hemorrhage than single infant births. Hemorrhage can happen in minutes. Patients experiencing postpartum hemorrhage require medications, pressure and suction devices, and even rarely hysterectomies. Many need intravenous fluids and blood transfusions to keep them stable until the bleeding can be stopped. These resources are simply not available at home births, and a patient could easily bleed to death over long transport distances. It is not hard to imagine a scenario where an ambulance arrives saturated in blood with a dead mother. I understand the sponsor's goals to improve access to midwife care for patients throughout the state, but HB 1010 is not the way. Enacting this bill and disregarding the reality of health systems in New Hampshire will result in maternal and infant deaths. For these reasons, I urge the committee to recommend ITL for HB 1010.
Okay. Perfect timing. 10 minutes just ended. Any questions, Representative Merchant?
Thank you, Mr. Chairman. I'm sort of torn on somewhat. If I understand the issue of free birthing, and that seems to be something that women want to gravitate towards, that in itself has a set of risks associated with it. Balancing that with the ones that have access to a nurse midwife, which also has risk associated with it, I'm trying to figure out how do we somehow ensure that those who want free birthing have some access to some care and not something all of a sudden it's done at the very last minute through an ambulance ride, which may not be called for. So how do we somehow balance the two ends?
Yeah, that's a good question. There are other places in the world and even other states that have very integrated health systems, meaning that they have rules and regulations set up with specific criteria for when to transfer during labor or postpartum to a facility. And many of those facilities are within close distance. One example is in Washington State. They do home births of low risk. I'm not talking about these high risk scenarios, but they do more home births there. But the average distance from the hospital there is going to be 2 miles. And I would say in terms of the people who want free birth, I'm not sure this bill is going to find providers out there who are willing to take on all these high risk scenarios. I don't think it will address the problem of people wanting to do home free births. I think there's other ways to do that. And I think people have spoken before have brought up great points, including like, let's have a conversation on how we can do more breech deliveries. But this is not the way.
You have a follow-up?
I think you've answered the question. I'm trying to, again, balance the free birthing movement, if you will, and their rights to do free birthing, but still have access somewhat to some medical care if they elect to do that. And that's what I'm not sure where to go with it. So, but thank you for what you provided to me. I can look at what's going on in Washington, some of the integrated care, because there are two sets of risk factors in either scenario.
Okay, other questions? Seeing no other questions, thank you. Also signed up to speak is Representative Kelly Potenza. Representative Potenza, you've asked for 2 minutes.
I'm here in support of this bill because I support choice, and it's been my oldest is 17 since I had them, and I had them in a hospital. But I'm just going to use my personal experience. So I come from a family of big babies, and so I was 10 and a half pounds. My brother was almost 11, and so they said I was going to have big babies, and they wanted to schedule me a C-section and all of those types of things. The pushing level of surgical procedures is huge. And I could give 100 stories of fellow mom friends that were in those same situations. And so I'm sure that maybe this bill would be amended. I just believe that that it shouldn't be a disqualifying factor just because a mom had a C-section or two. A lot of these people were pushed into having them. One, they make a lot more money than having it just be, in a hospital. We know that for a fact. And my personal experience is having that level of choice. So I would hope that there would be, something that comes forward to support this effort. I think there was a lot of statements that were said that are just not true in regards with midwifery and things like that. It's one of the oldest professions on the planet. So before we had hospitals and all these big, huge, fancy things, babies have been delivered in homes, which are different than free births. Home births have been happening for a long time, for hundreds of years. So one of the doctors that spoke here, I saw for about 4 years. And he used to wear a button that said, "I trust women." And I think we have to trust women. Thank you.
Thank you. Any questions? Seeing none, thank you. Also signed up to speak is Dr. Cecilia Clemens, representing herself. And you've asked for a little over 3 minutes. The closer to 3 minutes you can make it, the better. Thank you.
Good afternoon. My name is Dr. Cecilia Clemens. I'm a board certified OBGYN. I am the Dartmouth Manchester OB Division Chair and the Section Chief of OBGYN at Catholic Medical Center. I've been delivering babies in the state of New Hampshire since 1997. I've worked with midwives my entire career. I collaborate with midwives both in the hospital setting and when accepting transfers from out-of-hospital midwives who are attempting out-of-hospital births. I deeply respect their practice and value the midwife-physician collaboration to provide the best maternal, fetal, and neonatal outcomes. I am a proponent of vaginal birth, including for those women with twin gestations, malpresentation, and those who have undergone multiple prior cesarean births. I disagree with previous testimony that the state of New Hampshire does not allow, or hospitals in the state of New Hampshire do not allow vaginal births after 2-3 C-sections. Come to CMC. I disagree that vaginal breaches are not allowed. Come to CMC. I teach them, we do them, and people who have sat in this chair saying that they are not allowed in the state of New Hampshire are wrong. I'm speaking today in opposition of House Bill 1010. The American College of Nurse Midwives states that midwives must provide complete, accurate, and accessible information for patients to make informed healthcare decisions. Patients who desire home birth should review evidence-based information on its risks and benefits from their midwife. Patients should be informed that although planned home birth is associated with fewer maternal interventions than planned hospital birth, it is also associated with a more than 2-fold increased risk of perinatal death and a 3-fold increased risk of neonatal seizures and severe neurologic dysfunction. A recent study showed that home labor after cesarean was associated with an intrapartum fetal death rate of 3 per 1,000, as compared to 0.13 per 1,000 in the hospital setting. This statistic highlights that home labor after cesarean would increase neonatal morbidity in the state of New Hampshire. Why would the legislature want to create a policy that increases infant deaths in New Hampshire? While a woman who has had a prior cesarean delivery is not a good candidate for home births, other pregnancies are good candidates. Recent studies report comparable perinatal mortality rates among planned home and hospital births describe the use of strict selection criteria for appropriate candidates. These criteria include absence of pre-existing maternal disease, a single fetus in the head-down position, at term, in the absence of prior uterine surgery, including previous cesarean delivery. Let me summarize. Based on population data and rulings from the governing body of obstetricians, fetal malpresentation, multiple gestation, prior cesarean delivery are all absolute contraindications to home birth. House Bill 1010 explicitly rejects decades of evidence-based research and dismisses the governing body for maternal safety in the United States of America when it proclaims that there shall be no rules limiting care by a midwife for women with these conditions. I have personally been involved
Please
and can
start wrapping
provide.
up. Please start.
multiple examples of hospital transfers for women who have attempted an out-of-hospital birth. These examples unfortunately have concluded with neonatal transfers to tertiary care centers with separation of moms and babies, intrauterine and neonatal deaths, maternal hemorrhages due to uterine damage requiring hysterectomy, and not insignificant, birth trauma for mothers after their emergent, unexpected, and unprepared transfers to the hospital. Every word of House Bill 1010 rejects safety and will increase the deaths of moms and infants in New Hampshire. This bill is terrifying and should be opposed.
Thank you.
Thank you.
Any questions? Representative Shapiro and then Representative Tellez.
Thank you, Mr. Chairman. You said that you were a supporter of midwives and of patients having choice. So let's say there was somebody who had a certified, what is it, a certified professional midwife, and they had formed a trusting relationship with them, and then sometime in the third trimester, a high-risk situation emerged, and either because the law as it stands or because the judgment of the soon-to-be mother and the midwife, they decide to transfer their care to a hospital, to you. So to what, in that case, to what extent would the midwife who had a good relationship with the mom-to-be, to what extent would they be welcomed into the hospital process? Would they, to what extent and in what manner might they be able to be involved in the birth in the hospital?
That's a great question. I take phone calls very frequently on call at the hospital from out of hospital midwives who are asking to transfer patients to the hospital. Sometimes they call, sometimes they don't call. I always encourage them in that discussion to present with the patient for a person-to-person handoff. I always invite them to stay and act as a support person. In a hospital, obviously, an out-of-hospital midwife does not have hospital privileges and can't act as a clinician, but they are more than encouraged to stay and bridge that relationship with the hospital setting and the person that they've been caring for. I absolutely am 100% advocate for midwives staying involved.
Representative Tellez and then Representative Weber.
Thank you, Mr. Chairman, and thank you, Dr. Clemens, for taking my question. So prior speakers have reminded us that for millennia, women have been giving birth at home. So I was wondering, and thank you for explaining that it's, and other people also explaining, it's less about the role and it's more about the setting that is really important. So can you remind us or paint a picture of what the birth outcomes were like historically versus current day? Because none of us were alive and we don't really remember how much, how many women died, how many babies died, what these outcomes that happened all the time that were considered the norm that are very different from what the norm is for us now.
I don't think I am saying something that is unknown to this committee, that the maternal fetal outcomes in the United States of America is almost at the bottom of the list. To answer your question, what's different in all of the millennia is that we were in a developing country. We had to accept a perinatal mortality of 15-20%. That is no longer acceptable in the United States. How can we as a country say that it is okay for us to make rules that increase risk to moms and babies? And correct, we haven't always, they've been delivering out of hospitals for millennia, correct. We also hopefully have decreased the maternal and fetal and neonatal mortality since that time.
Representative Weber.
Thank you, and thank you for taking my question. I think mine is a follow-up perhaps to Representative Shapiro. You stated that a certified professional midwife coming into the hospital with a patient would not have hospital privileges and therefore would be a support person but not a clinician. So my question is, do you have in your practice certified professional midwives, or do you have only nurse midwives as a hospital practice?
In our hospital, we have certified nurse midwives who are advanced practice providers who have master's degrees, nursing degrees and master's degrees.
So you don't have affiliated certified professional midwives?
Correct.
Okay, thank you.
Representative McLean?
Yeah, thank you, Mr. Chair, and thank you for taking my question. So, whenever you're working with a patient, we hear from all the different doctors who testified, we make our recommendations. And as a doctor, you can recommend, but you can't command. And so there are going to be some women who are going to, in spite of your counsel, they're going to kind of choose their own path, and maybe that involves a home birth. And so kind of the testimony that I'm hearing, it almost sounds like these women are kind of cut loose. So, and there's no real place, it's either you're all in or you're all out kind of thing, and that kind of following on some of Representative Merchant's concern. So if you look at this bill, is there anything about this bill that you would maybe salvage to give these women a softer place to land, or anything else that you would maybe recommend?
Well, I mean, I agree with the ongoing need for discussion, and I agree with your initial statement that, it is our job as physicians and providers of women's health is to give information, and women absolutely are able to make their own decisions. And I work in a practice where I have women come after 4 C-sections, 3 C-sections, breech, everything that we're talking about today, and try to have a risk-benefit discussion, providing patient autonomy. They get to take the information that I give them and make a decision. And when they make that decision, it is my job to support them in that decision. And even if it's not something that I would personally choose myself, I am the physician that will support them, and my staff will support them. So I recently delivered someone who had had 4 previous cesarean sections who did not want a repeat. She came from a home midwife, and she attempted a vaginal birth. We supported her through that process, and ultimately she required a C-section. Ultimately, she asked for a C-section. She was in the supportive environment. I think that what we're talking about, there's nothing in the bill as it stands to answer your question that I support, but I believe that there needs to be ongoing discussion. There needs to be ongoing education with our public to understand that women do have options. They can come to hospitals and be cared for by midwives and have that safety net.
Any other questions? Seeing none? Okay, thank you.
Thank you.
Also signed up to speak is Emily Burris, representing herself. And you've asked for 3 minutes.
Good afternoon, committee chair and committee members. My name is Emily Burse, and I'm a resident of Lebanon, New Hampshire. I'm a certified nurse midwife and the director of the midwifery service at Dartmouth-Hitchcock Medical Center. I've been practicing as a certified nurse midwife since 2014. During my career, I've attended births both in the hospital setting and at a birth center located outside of the hospital. I'm here to speak in opposition of House Bill 1010. I'm concerned this bill will put birthing people, their babies, and the midwives who care for them at risk. This bill undermines and compromises my own profession's ability to uphold the quality and safety of the care we provide as midwives, and it undermines the New Hampshire Midwifery Council and established midwifery certifying organizations who set our standards of practice based on expertise and data. This bill goes against expert practitioners' advice on who is a good candidate for home birth. While I'm a certified nurse midwife and therefore not regulated by the Midwifery Council, I share much of the same philosophy, training, and fundamentals of approach as certified midwives and have deep respect for them. As a midwife, I strongly believe in the process of normal birth. I strongly support reducing barriers to accessing midwifery care, including access to nurse midwives and certified professional midwives, including things like improving insurance coverage and financial support for midwifery services, increasing programs that educate and train midwives. I also believe that home birth is a safe and great option for many birthing people, but I do not believe it is a safe option for all birthing people. Research shows that home birth in the US is a safe option for people who are low risk. I think HB 1010 is too broad in terms of who it endorses as a good candidate for home birth. As a midwife at Dartmouth Hitchcock Medical Center, I'm happy to provide midwifery care to people who have had 2 prior cesarean sections and desire a vaginal birth, with the support of the OBGYN physicians and anesthesiologists who work in the hospital with me. People with 2 prior C-sections, as others have said, are at higher risk of complications like uterine rupture. If a uterine rupture occurs, a woman and her baby need immediate access to anesthesia, a C-section delivery, most likely blood products, and a neonatal intensive care team, all of which are immediately available where I practice. Minutes matter in these cases. My professional organization, the American College of Nurse Midwives, states that the safety of home birth is optimized by assessing the appropriateness of the woman and family for home birth, attendance by a qualified maternity care provider, which I believe includes CNMs and CPMs, and integrated systems that support collaborative care. In summary, I oppose HB 1010 and recommend it be reviewed to ensure it truly upholds patient autonomy, the right to informed decision, and upholds the highest clinical standards of midwifery care. Thank you.
Okay, thank you. Any questions? Representative McLean.
Yes, thank you, Mr. Chair. Just a quick question. I didn't get your name.
Emily Burse. I have a written statement that I have copies of that I can.
Thank you.
Do you have enough for the whole committee, or?
Yes.
Okay, you can put that out now if you want.
Okay.
Okay, sure. Representative Leon.
Thank you, Mr. Chairman, and thank you for taking my question. I apologize. I'd had to go chair a subcommittee on Alzheimer's, so I didn't hear everything that was here. My question is, in my experience, when I had a breech presentation on my 3rd child after rapid births for all of them, I was told that I would be required to have a cesarean unless I had a very fast birth like I had with the others, where they didn't have time to prep me for surgery. In your practice, are you able to deliver breech babies?
I, as a certified nurse midwife, do not currently deliver breech babies because I haven't had the experience or exposure or training to feel confident in that area. But I know that there are physicians within the Dartmouth Health System who do feel skilled in that area and can make that available to patients who want that.
Thank you.
Representative Mazur.
Thank you, Mr. Chair. Thank you for taking my question. I heard you say at the beginning, you said, maybe I heard it wrong. When you said birthing people, can you please clarify who that includes?
I think so. Not all birthing people identify as women. And we support birthing people regardless of how they identify.
Other questions? Representative Shapiro.
Yes, thank you, Mr. Chairman. We've heard testimony, equally forceful testimony, that breech babies are not delivered vaginally in New Hampshire. And then we've heard from several physicians or from you as a nurse midwife that they are. Any ideas about why there's those differences and ideas about what exists and what doesn't exist?
I'm sure other people could comment on that as well, but I think it goes back to the training and experience of the individual provider and the team that they're working on. It is in some way a dying art. I think many people historically were very comfortable providing breech birth, and midwives in many settings are those providers as well. I've worked around the world where midwives do breech deliveries. I've worked in Africa where midwives do breech deliveries, and that's the standard of practice. But I think in the United States, a lot of providers don't have the training to feel comfortable offering that as an option, but some do.
Follow up?
I guess I'm wondering more about why there's a very different perception among the medical providers that talked about this as an option and other people who are testifying. That may be an impossible question to answer, but we're hearing two different truths, as we often do, and I'm wondering if you could shed any light on why we're hearing that.
I think that is a difficult question to answer. I imagine there may be parts of the state where the nearest provider who feels comfortable in doing a vaginal breach is far away or potentially difficult to access.
Other questions? Seeing none, thank you. Also signed up to speak is Nicole Roach. You've asked for 2 minutes.
Hello, my name is Nicole Roach. I currently work as a doula, midwifery assistant, and I am also a nurse. In the time I've been attending births, I have attended a variety of births in different settings all across the country, in various different states, where the law is different in all of them. So I've seen many different home births that don't necessarily happen here in New Hampshire. Most of the births I have attended have been at home under the care of a midwife. I have seen women birth twins and breech, either footling breech or, butt first, feet first, safely at home. I have also attended births where women have had multiple cesarean sections prior to choosing to have a baby at home under the care of a midwife. These women have done so safely as well. I have actually attended a lot of births in other states that would have been illegal in the state of New Hampshire. Occasionally, women in New Hampshire even choose to leave the state to have their babies in states like Massachusetts so they can have a safe home birth that they desire with a skilled midwife. Everything mentioned in this bill is considered a variation of normal. I know after some of the testimony of some of the obstetricians, apparently there is a little bit of a rift in who considers what a variation of normal. But to me, and in my experience, attending births in hospital, birth centers, and at home, breech, twins, and, VBACs are all variations of normal and can absolutely be attended safely by midwives in the home setting. Midwives all over the world are attending births like this safely at home. Midwives directly south of us in states like Massachusetts and Connecticut are attending births like this safely at home. Most of my clients from out of state are shocked when I tell them that they would not be able to have a skilled midwife attend their birth at home if they lived in New Hampshire. I was shocked too when I learned about the restrictive nature of midwifery care in home birth in New Hampshire. Most people I talk to, especially those people that live in states like Massachusetts and Connecticut, are also very shocked about the restrictions that we have here in the state of New Hampshire. Truthfully, this bill goes beyond midwifery. This is women's right. Women deserve the autonomy and the respect to be able to evaluate the risks and benefits between healthcare providers and birth settings. Because, as many people know, no choice you can make here goes without any risk, right? You choose to birth in the hospital, there's a risk there. Choose to birth at home, there's a risk there. There's always some level of risk.
Please start wrapping up.
The passing of this bill would be a measure of risk reduction because under the current restrictions, women are either forced to have an unwanted hospital birth. I refer to that as a risk because the maternal death rate in the hospital is actually higher than at home. Or their other option is to have an unwanted, unassisted birth at home without the care of a midwife. I feel it is important to mention that the passing of this bill would not force a midwife to take a client that she does not feel comfortable with taking. It only gives midwives the freedom to work to the full scope of their practice and to not have to abandon their clients due to variations of normal that they might be comfortable dealing with. There are continuing educational resources available for midwives to learn more about these variations of normal and to develop their skills. The Coalition for Breech Birth, Breech Without Borders, and Twins Trust are examples of organizations that provide trainings for doctors, midwives, nurses, doulas, and other healthcare providers and birth attendants. As a woman, a mother, and a birth professional, I am very grateful for this bill. I think this is a positive step in the right direction. I hope there are similar bills to follow that remove the unnecessary restrictions surrounding birth in New Hampshire. So in closing, I am in support of this bill.
Thank you. Any
Thank you.
questions? Representative McLean.
Thank you, Mr. Chair, and thank you for taking my question. So you mentioned experiences that you have had in Massachusetts and Connecticut.
Yes.
Do you know if the provisions that are being proposed in this legislation are already legal in Massachusetts or Connecticut?
They are in both of those states, yes. So I was just going to say that there's just less restrictions and regulations in general in those states.
Other questions? Representative Leon.
Thank you, Mr. Chairman. Are you telling me that had my child not returned back to a cephalic, the presentation of head down, I could have actually fled the state of New Hampshire and had the birth that I wanted safely in another state to get that necessary medical care?
I can't for 100% say that it would be safe with no complications, of course, but there would have been more than likely a midwife in Massachusetts that would be willing to receive you as a client and attend your birth and provide you with medical care in a home setting. You know, you'd need to get like an Airbnb or something, obviously, if you were to leave this state. But yeah, this absolutely, I have seen this happen and I have attended births.
Thank you. That's good to know. Should I end up in that situation again?
Other questions? Representative McLean.
Thank you, Mr. Chair. Actually, it's a question for you. So I'm wondering, in light of that, would it be possible to maybe have the committee researcher maybe do a side-by-side on that just to confirm the details of that?
Sure. She's apparently not here at the moment, but
Yes.
Christina Dyer, are you out there? I don't think so. Yeah, I'll check with her on that.
Thank you,
Give
Mr.
me a note on that or send me an email or something, okay? Any other questions? Seeing none, thank you. Oh,
Well, this again,
Representative Murphy.
following up on Representative McLean's inquiry with the chair, I'd like to add to that inquiry with the research if we could. One of the industries that probably knows about risk more than any one of us is the insurance industry. And I'd like to look at the various insurance policies and risk format, if you will, across various states, because if there are in fact variations in state law, there may be variations in liability insurance because it's based upon risk factors. So if we're really trying to get down to measuring risk, a good place maybe to look is the insurance industry, because if anyone knows risk and monitors risk more than anyone else, it's the insurance industry.
Sure. Did you get all that, Christina? Okay, all right. Any other questions or comments? Seeing none, thank you.
Thank you.
Representative Tejas.
Yeah, just to clarify, I would propose that we don't just look at Massachusetts, right? That if you're going to compare what's happening in other states that's relevant, it should be comprehensive.
Thank you. Okay, also signed up to speak, and I'm not sure about this last name, Catherine Brainerd? From Brainerd, okay. And you've asked for 3 minutes. We need to leave shortly, so please keep it to 3 minutes.
My name is Catherine Bramhall. I'm a certified professional midwife in the state of Vermont and New Hampshire. I also serve on the Office of Professional Regulation in the state of New Hampshire, which is the equivalent of the New Hampshire Midwifery Council. I'm also the owner of Gentle Landing Birth Center in Hanover, New Hampshire, which is 0.6 of a mile from on Buck Road from Dartmouth Hospital. I'm here to oppose the passing of this bill as it's written. What I want to say, there are a few corrections I'd like to propose to testimony here based on my profession and my 17 years of being a midwife and attending out-of-hospital births, having received over 700 babies in my hands and never having lost a baby. So, as we discuss this bill needs to be considered under the auspices of the New Hampshire Midwifery Council and the women and the midwives who actually would be performing any of these things to their licensure and to their experience. I'm the head of an international disaster relief organization that won CNN Hero of the Year award, that is CPMs that get called to disaster areas in low resourced areas where there are lots and lots of unfortunate low resourced opportunities to have babies. What I want you to know is that women in lower resourced areas in underdeveloped countries would give anything for safeguards to be in place. Those safeguards do not include the over safeguarding, quote unquote, of the American College of Obstetrics and Gynecology that has superimposed their idea of what is safe, not really being informed about what my profession's training. It is not just about attending a few births. It's a 3-year midwifery program of some sort or another, not just a high school degree. I consider that extremely degrading for the reputation I have. What I also would like to say in testimony is that the safety of breech, the safety in an out-of-hospital setting, either at home or in my birth center, which is not legal in my birth center, we don't have that. But the safety of the proposals in this bill have everything to do with not just taking a class or not just, having an experience of 1 or 2, but to have literally an experience inside when you're in an out-of-hospital setting, which you go, this is okay. The true experience and the true conversation that needs to be had with the complicated nature of this bill is how do we keep the resources connected up with out-of-hospital midwives who really do know their stuff. I don't know I have lots of OBGYN friends who go, I wouldn't have the steel in my spine to do what you women do. So when you're investigating the claims about CPMs, I'm going to back up the Midwifery Council that I belong to and say, please come to a meeting if you really do want to have questions, or email us the questions and get accurate information.
Please start wrapping your testimony. Yeah.
Thank you. I have one more thing to say, please.
Sure.
As far as risk goes, we hear lots and lots of sensational home birth death examples during testimony here, as well as out in public. The Washington Post did that article. What you also are not hearing, and I really want, as women have the option for autonomy in this transformational time in their life, the conversation should not be stopped simply because some Washington Post reporter wrote something, or some OBGYN out there. There's a famous OBGYN who spends a lot of time taking us down. What's the true information, and how do we weave women and birthing families into this conversation so that a complicated bill proposal can be actually rewritten or considered with everybody's needs and safety in taken into consideration? I oppose this bill as it's written. I hope that this bill is opened up for further conversation.
Thank you. Any questions? Representative Merchant.
Quick one. In regards to the certified professional nurse midwives,
Certified professional midwife, I
correctional
apologize.
nurse, is there a particular insurance company you folks use mostly, predominantly?
Yes, we are credentialed in all
Not
of,
credentialing. Who's
yeah.
your insurance carrier?
yeah, we have liability of 1 million, 3 million, which is required in order to be credentialed with
there a
health
name of the
insurance
company, ma'am?
companies. I'm sorry?
Is there a name of the company?
We use Southern Cross as it's MedPro, I think. Yes.
Other questions? Representative Murphy.
Thank you, and thank you for taking my question. So you are adamantly opposed to the bill as written, as you said. Is that because I know where your building is? You are literally neighbors to Dartmouth Hitchcock. You could throw a stone into their yard. So is it because it's not because of the distance, obviously, from where you are to having a backup source to take care of any troubles you may have? So is your opposition to the bill based on the indications for home delivery, meaning multiple previous C-sections or breech presentation, or so I'm just trying to understand why you were opposed, because I know that you are very, very close to a backup facility. So is it principally because of the indications for home delivery that you oppose?
No, I'm opposed to the bill primarily because because the bill isn't written accurately to address the things that need to be, what I think it was Beth who said, there's not enough in the bill that's written as it is to actually, what are the requirements that would make it safe for me as a midwife? I mean, I don't take chances, like I'm pretty conservative about what I do, but how do we build this in as a safety net for both the midwives who are certified and licensed in the state of Vermont by the Midwifery Council to protect the public, as well as offer choice so that over and over we've talked about women don't just go, sorry, I'm out of here because I'm just doing a free birth. We have to have this more comprehensive for protection of everybody. And I also want to say that the Massachusetts comparison is not an equal comparison. They're not a licensed state, so they don't have rules and regulations, just as you're looking that up.
Other questions? Seeing none. Okay, thank you. Also signed up to speak is Jenny Sweet. And you've asked for 3 minutes.
Am I good? Okay. Good afternoon. My name is Jenny Sweet. I live in the White Mountains of New Hampshire. I am a single mom to 5 boys, survivor of domestic violence, a doula trainer, educator, and I have been studying midwifery and physiological birth for over a decade. We cannot stay on this path because it is not working. Over the past 25 years, I have just been gestating, birthing, and raising my 5 boys and holding space for families birthing in the Granite State. Thank you so much for this opportunity to speak to the committee today. I am in favor of HB 1010. As I sit before you today, as somebody who has birthed 5 humans, walking away from the birth experience with severe birth trauma, I almost lost my life due to the egos and the bias of providers, one who is sitting behind me right now. Then I started sitting with hundreds of birthing people in our state, watching the maternal health crisis unfold in every location. We cannot keep doing what we are doing. Birth trauma and poor outcomes is not just, oh, it was hard. The research now shows us that the safest and healthiest way to birth a baby is vaginally with trained providers. Vaginal birth has a lifelong impacts on the child and the mother. We are playing God and we are harming our community by doing so. If we look at birth in New Hampshire by numbers, the picture is clear. I got the following statistics off of the New Hampshire Vital Statistics website. This is the data that we collect as midwives and providers off the back of the birth certificate. In 2023, 12,080 babies were born. Nearly 25 of those babies were covered by Medicaid. In 2020, 27.4 of all births in New Hampshire were by low-risk cesarean section. We ranked 36th in the nation during that time. I attempted to get the latest statistics off of the Vital Statistics website for 2023, but unfortunately, it wouldn't put out that data. In 2023, 1,749 babies were born to mothers who had had prior cesarean sections. 5 of those babies were born in freestanding birth centers and 18 were born at home. 434 babies were born in the non-vertex breech position. In 2023, 3,781 people were induced in the state of New Hampshire. Another 3,058 people had their labors augmented, but not a full induction. 1,020 babies were born with meconium staining, and 1,066 babies were admitted into the NICU. 7,702 babies were born with forceps. If you don't know what forceps are, they essentially take like the medieval things, they wrap that around your baby's head and they yank your baby out after they cut you like a piece of meat. 11 of those babies born by forceps were after the provider attempted to deliver the baby with a vacuum. In 2023, 118 people were admitted into the ICU, and I was very interested to learn that only 16 of those people were on Medicaid. We have an opportunity right now to shift things in a new direction by giving power back to mothers and midwives who feel comfortable attending these variations of normal. I urge you to pass HB 1010 with some amendments. We need to keep these important conversations, giving choice back to people in the perinatal community. If we are going to change the world, it starts with how babies come into it. 1 in 6 people experience preventable birth trauma. 80% of all pregnancy-related morbidity and mortality are preventable. The research shows us that healthy mom and healthy baby with midwifery care in out-of-hospital freestanding birth centers are the safest way to bring babies into the world. Again, breech twins and VBACs are variations of normal. Regulating these births brings great profit to the system and massive trauma to our communities.
Please start wrapping up.
The average home birth not covered by insurance will cost around $5,500. A medical induction that leads to an unnecessary cesarean section due to a cascade of interventions runs upwards towards 60 grand. Did you know that the #1 cause of maternal mortality in the state of New Hampshire is substance use, yet a newborn's first introduction to opiates is in utero? We are using fentanyl. It is the #1 pain medication used in labor and birth right now,
Ma'am, please
and we
start
are
wrapping
not
up your testimony.
disclosing that to people.
Ma'am, please start wrapping up your testimony.
All these births believe me that the system is profiting off the people and stealing autonomy from healthy mom and healthy baby, and then filtering them into a system that is currently imploding and harming people while the medical system tries to fix something that is not broken.
Okay,
And then it profits
Let
off
me
of
stop
these.
you there. Are there any questions? I see
Sorry.
none. Thank you.
Thank you.
You've given us a lot of good information. Thank you. Okay, I have no one else signed up to testify this afternoon on HB 1010. 2 people did sign up in favor of it, and 1, 2, 3, 4, 5, 6 signed up against it in the blue sheet on the back.
And online, there were 106 people in support and 26 opposed.
Okay. There are no other bills to be heard this afternoon, so I'm closing the public hearing on HB 1010, and we stand adjourned. Thank you.